So if we could ask people to take their seats so we can move on with the program this morning. The next speaker I'm privileged to welcome is Dr. Joseph Misdraji, who is a pathologist from the Massachusetts General Hospital. He is an associate professor of pathology at the Harvard Medical School, and he's the director of histopathology at the Massachusetts General Hospital. And if anybody has been following the literature of the pathology of this disease, his name comes up repeatedly in the publications around this disease. And so I'm hoping that he'll be able to shed some light on the confusing nature of this. And also, he told me that he was able to attend that consensus meeting in Basingstoke. That there's going to be a follow-up to that meeting in October at the peritoneal carcinomatosis workshop that's held every other year in Amsterdam, at which time we're hoping to have a consensus that will help the pathologists describe this disease so that the medical oncologists and the surgical oncologists and the patients can understand what it is that we're dealing with and that we can come up with better treatments for people. Thank you.
Thank you. So, yes, this is working. I hear myself. Thank you, Dr. Lambert, for inviting me to speak to you. And I have to say it was an interesting challenge being presented with speaking about pathology to people who are not pathologists, because it's a lot of visual stuff in trying to explain that. And what I'm going to try to do is take you through the history a little bit of why is there this question of, is this cancer, is this not cancer, and what do we call this, and why is there so much confusion? And I recognize that as we're talking about these controversies, there's a lot of positions you can take on whether this is cancer or not cancer, on patient advocacy issues, or trying to get insurers to pay for this or not pay for this, or getting a blemish on your insurance record. There's a lot of sort of social issues that are involved in this. And I'm not going to necessarily cover that, but I'm aware of them, and I understand that a lot of you may have those feelings about that particular issue. But we're going to look at this more from the pathologist perspective of why is this so confusing to pathologists? And recognize that what pathologists do, of course, is we look at slides, we look at tissue, and we render a diagnosis. Sometimes a little bit unaware, perhaps, of what the impact of that report will be down the road. But if there's any confusion on our part, that confusion is going to translate to a misunderstanding on the part of the surgeon, a lack of clarity on what to do for that patient. And so that's where our role becomes so important in terms of being able to communicate effectively to people who are reading a report. So again, everyone I think knows this. The appendix is on the end of the colon, so I don't want to belabor this since I think everyone's aware of this. And this is a normal appendix. It basically looks like your pinky, and there's a bit of fat here. This is where blood vessels come in, and this is the appendix here. Here it's been detached from the colon. Is that really pale? That looks pretty pale to me. So this is an appendix on a microscopic view, and this is the center. There's the lumen in the center of the appendix. And then this is the lining, the epithelium, we call it. You can see that it's basically a stellate shape, but it's smooth, and then it has all these invaginations and what we call the mucosa. So this whole segment is the lining. And then there's these blue nodules, which are lymphoid tissue, immune cells. And those immune cells, again, is part of the role of what the normal appendix may do. We could say very simply, in a way, part of it is a school to teach your immune system how to handle bacteria in the colon and to keep them in check. So this is an appendix that clearly is now abnormal. It's very dilated, and it's filled with mucin. And just looking at this grossly like this, it's called a mucocele, a dilated structure filled with mucin. But it doesn't tell us, just looking, is this a tumor that's causing this? Maybe the appendix got obstructed and it got filled with mucin. So we don't know yet what's causing it, and we have to obviously look at it microscopically. And this is what it looks like microscopically. And what we see is replacement of that lining. And rather than having that stellate lining with the invaginations, now we have this kind of like octopus fronds that are going into the center. Notice also that we've lost the lymphoid tissue, so in this particular appendix. So you see that we don't have those blue nodules anymore. And now we have like these fronds going into the center of this abnormal epithelium. And this is a comparison with what was normal. You see here, it was a flat lining with these invaginations and the blue nodules, and here it's become like these fronds into the lumen. So this is an adenoma of the appendix. At this point, still benign because it's confined to that center. But sometimes as mucin begins to accumulate in these tumors, it's the same tumor, but it becomes dilated and flat. And so here it's the same tumor, again, very confined to the center of the appendix, but now it's flat or maybe this undulated, tufted lining, but the same tumor. So slightly different look, same idea, it's still benign. And now we have an appendix that is, again, dilated. It looks like a big toe, and for the most part encased and fine, but this little nubbin, this tiny little nubbin of mucoid tissue with a little bit of hemorrhage around it is the issue here. And when you look at a microscopic view, I don't know, can you darken that a little bit? Because it's very pale to me. We're stuck. Okay, so when you look at a microscopic view, it's very dilated, and this is the tumor, and then there's this explosion of mucin on the outside of this. And so it looks like it's ruptured. I mean, it looks like the sense of a balloon that blew up too much and then just ruptured. And that would be the impression that pathologists would get from this. And unfortunately, that little tiny hole allowed tumor cells to escape and to go into the abdomen where they start to deposit as tumors in the abdomen. And this is the colon up here with the muscle that you can see here. And this is the omentum, and it should be almost like a membranous, translucent, like cellophane. And instead, there's these globs of mucinous tumor. And it gives the impression almost of being like slimy styrofoam. That kind of firmness, slightly rubbery sort of appearance. You can see here's some blood vessels coming to this. Again, it should be a thin membrane, and instead it's become a big, thick sort of slab of tissue that here we've cut through, and you can see the quality is almost like a styrofoam, like a slimy styrofoam. Now, despite the fact that it looks so solid, actually on microscopic impression, and I'm sorry, this is so pale, it should be a pale blue, and that's all lakes of mucin. And then what you see, actually you can still barely see here, but these are strips of epithelium. And they're still clinging together very well. They're very what we call low grade. They're doing a very good job at looking bland and holding together well. But clearly they're growing now outside of the appendix, and that's a problem. And when you look at higher magnification, again, they're really holding together well. And you have to sort of take it on faith if you've looked at a lot of tumors in your life that this looks really bland for what we would think of as cancer. It looks really just, to a microscopist, they're really bland, quiet-looking nuclei. Oh, yay, thank you. I would take the brightness down even further if you could. Keep going, keep going. Keep going. Go, go, don't be shy. Okay, I'll take your word for it. I'm not an AV person. So here we see even in higher magnification. Again, notice the things that looks very much like the normal lining of the appendix. Maybe a little bit abnormal, but not nearly what you'd expect for cancer. And that was part of the difficulty, I think, over the last 50 years when people would look at this and they'd say, it doesn't look like cancer. It doesn't look as bad as cancer. But obviously it's growing in a place where it shouldn't be growing. This is an ovary. Actually, now a normal ovary should look something like a pecan, about the size of it, about the kind of the texture of one without the shell. And instead, what you see here is probably 3 or 4 inches, and it's filled with mucin. And this is a frequent organ that is secondarily involved by the tumor from the appendix, and it looks very similar. Again, this lining of very bland-looking epithelium that you can see has this mucin on the top of it, and this was all, again, this light blue that's filled with mucin. So this bland tumor, and it usually is bland like this bland tumor that seemingly ruptured from the appendix and seeded the abdomen has been the source of a lot of controversy over the last 50 years or so. And one of them is that sometimes the appendix can be relatively small, but the ovary is quite dramatic. And so people, especially people who are interested in gynecologic pathology, who looked at the ovary and would look at pseudomyxoma, would say, we think it's from the ovary. And some people would say, no, I think it's from the appendix. Some people would say it arose from the abdomen primarily, just, as a third place things can start. And so this was originally quite a controversy until probably early 1990s, where people finally settled that issue and said, you know what, almost all of these cases are from the appendix. So of all these controversies, you can say one at least is completely settled. But there are other controversies that aren't completely settled, and as you know, the classification of what are these tumors is still an issue. And still today, the treatment, while there's a lot of centers like this that have standardized their care, there's a lot of places that don't standardize their care, or that don't necessarily agree with HIPEC. And so there's still some work to be done in terms of getting consensus on what's the best treatment for pseudomyxoma peritonei. So to understand the classification of the appendix, I'm actually going to take you to an organ that's a lot easier to understand, and that's the colon. And this is someone's colon, and the normal part is these horizontal, delicate folds, but all these warty growths on this are abnormal. These are all adenomas or polyps. And when you've heard, I'm sure many of you know, have had friends who've had colonoscopy or yourselves and have had a polyp removed. And the most common polyp is an adenoma, and it's benign, but can lead to cancer if you leave it in for a long enough time. And this is what it looks like. So this is the wall of the colon here, the muscular wall. And this is that same lining that we had looking in the appendix, this ribbon. And these purple cauliflower heads are all the adenomas. And again, if they're on the lining and you just scoop them out, you're done. They're benign. And here it is on higher magnification. Again, this is the mucosa, so this low, this is normal. And then here, this bump, it looks a little bit darker than the normal. This is the adenoma. And then this is cancer in the colon, and there really isn't an intermediate. It's either an adenoma or it's cancer. And what is cancer is essentially you start getting destructive invasion of the underlying tissue. So here's the adenoma, here's the normal lining, and all these glands that are infiltrating down into the muscle and beyond are cancer. And so it's fairly simple. You only have benign or malignant. And is there this destructive invasion by these glands or not? And when it spreads to the peritoneum or the abdomen, it looks very similar. So again, we have these glands, and they look, I'll show you on higher magnification what they look like, but they're spreading through the abdomen. And a lot here of scar tissue, this body's reaction against this tumor. Doesn't like it, starts producing what we call desmoplastic response, so sort of a scar reaction to this tumor. And again, sorry, this is so pale, but these are normal cells. Look at the size of this guy, and then look at the size of these. So this is what a pathologist would say, oh yes, this looks malignant. They're very dark, they're dividing, they're very irregular. They have all these features that we recognize as cancer. So from the colon, when it spreads to the abdomen, there's no question. Everyone would agree, this is cancer, this looks bad, and that's why there really isn't a controversy with colon cancer in terms of its classification. So if we summarize, in the colon, we can really skip this stuff, but this is normal, the polyp, benign. If it's invading, it's cancer. End of story. So there are some of those that correlate to the appendix. So for instance, we do have lesions in the appendix that are completely confined in the lumen. And here it's more the octopus frons, but it's confined in there. If you'd remove this, there's no problem. So we can call this an adenoma. And there are definitely cancers in the appendix, where here we have the lumen, again, those frons inside the lumen, and this destructive invasion outside of the lumen that everyone would agree, and there's no controversy here, everyone would agree this is adenocarcinoma of the appendix. But we have issues in the appendix, and the issue is that there's something that is not quite one or the other. So what is it exactly? Well, you have, here is the lumen, where you have this little villus frond, and then you have this reaching tongue going down. Is this invading? Is this the same as those glands invading? Is this maybe dissecting or herniating, or all kinds of words that you can use short of saying it's invasion, because it's very bland looking. And if there's nothing in the abdomen and you remove this appendix, this person still survives. So you don't want to call this cancer, do you? Because, I mean, this would be terrible to have a diagnosis of cancer and be over-treated if they don't need that. So what do you call this? And that's sort of the problem. Another case, here's the lumen, and you have this dissection through here, or invasion. What is this exactly? And again, if there's nothing outside the appendix, this person survives. If there's something outside the appendix, you have the whole issue that many of you face with pseudomyxoma peritonei. And so you kind of want one name that you can apply to this, but the circumstances seem to dictate what you're going to think of this. And then you get something like this, a very dilated appendix, where you see some of these, this is the wall, this pink band out here, but you can see in some areas the wall is very attenuated, very thin, almost breached. And so again, this is the kind of thing, it's not completely benign, but if there was nothing outside, person is going to do fine. If tumor has escaped, that's going to cause a problem. And so again, it started to create this little bit of a problem with how do you define a tumor if it depends on the circumstances. And I, as a pathologist looking at this, may not be aware of all the circumstances. I might not be aware of what's in your ovary or what's, you know, around your liver. And so it makes it sort of confusing to sort of second guess that based on what I'm looking at. And finally, you have something that, quote, bursts, that ruptures and extrudes this mucin into the abdomen. And again, if there were no tumor cells out here, there's a low risk that this would come back because obviously it has escaped. And while I may not see tumor cells, I don't know what's left behind. But if I do see tumor cells in here, then there's a high risk that this will come back because then we know it had the capability of spreading. And I'm already seeing evidence of that. But again, it creates this issue of what do I call this? If some people are going to survive and do well, some people are going to need more treatment, and it creates this problem. And again, once you have extrusion of the tumor into the peritoneum, you can start having accumulations in the peritoneum. And then I think we all know that this is sort of at least a low-grade progressive process that will be a problem. So again, if we look at pseudomyxoma peritonei itself, the classic situation is that it's very low grade. And again, if you look at these nuclei, these are normal, and judge these nuclei to that, and they look very similar, very small. All the cells are holding on. They seem to look very much like the lining of the colon. So they're doing an excellent job mimicking their counterparts in normal structures. And that's what a pathologist would say is low grade or benign looking. And that's where the confusion came in. There are examples, of course, of higher grade tumors. So here what we see is a lot more complexity. Rather than just a simple strip in the abdomen, now we're seeing this kind of crazy cribriformed or complex growth, this complex growth. And when you look at these nuclei, again, judge this as a normal one. This is much larger, has a big nucleolus, we call it, in the center. They are jumbled. So this would be a little bit more high grade, yet they're still holding on pretty well. So I don't have a picture of signet ring cells, but the idea there is that these cells are at least holding on. Once the cells no longer have the capacity to hold on, they can start to invade a single cells. And you can imagine if I was trying to push through this crowd, but I had to hold on to 15 friends, how slowly I would get through this crowd. But if I can let go of everyone, I can race through you a lot faster. And that's the idea. If those tumors are not even capable, if those cells are not even capable of holding on to one another, they can get through tissue much faster than if they have to drag all their friends with them. And so that's the idea. So at least these do look worse. And everyone would probably agree that this should be called something like a low-grade cancer or an intermediate-grade cancer, but at least they're holding on to one another. In 1995, Bridget Ronette at the Johns Hopkins Institution produced a seminal paper where she looked at pseudomyxoma peritonei and she classified them based on how bad they looked, from the very bland to that intermediate to even looking even worse. And she found something that's still very important today, that never mind what the appendix looks like, if you look at what the tumor is in the abdomen and you can grade from well to intermediate to poorly differentiated, that has impact on prognosis. And that's something that still pathologists sometimes don't recognize, but is a key part of what people are trying to get into the WHO, the World Health Organization, to recognize and ask pathologists to do. Now, at the same time that this was critically important information, she introduced a term that has also been the subject of controversy, which is she ended up calling the lowest grade, that blandest group, disseminated peritoneal adenomucinosis. And if you take that term apart, disseminated, spread, peritoneal, obviously, adenomucinosis, that term actually implies it's benign or came from a benign tumor. And she said that all of those patients had an adenoma in the appendix, a benign tumor that has spread into the abdomen with this benign glandular stuff that's unleashed, basically, in the peritoneum. A lot of pathologists, especially GI pathologists, that are looking at colon cancer and saying, you know, you got two choices. It's either cancer or it's not cancer. And they would say that is not a good term, that that's misleading to people to let them think that they have a benign condition and that it's potentially under-treating people. So that particular term, while I think the principle that you can grade people and predict prognosis is, I think, important, that particular term has been very controversial. And a lot of people, including the WHO, have not adopted that term. So some pathologists use it, some don't. And you can see where that can cause some confusion if not everyone's speaking the same language. So essentially, the war is on, and you have two different philosophies. You have people that will look at the appendix tumor and say, you know, it just looks like one of these tumors has burst and unleashed itself into the abdomen and allowed it to seed. So they're comfortable with this idea that it's an adenoma, benign, that ruptured and then seeded the abdomen with this benign-looking but progressive neoplastic epithelium that we'll call DPAM. And other people say that's ludicrous. If you have anything growing in the abdomen outside of the organ of origin, you have to call that cancer, even if it's low-grade cancer. And therefore, going backwards, the appendix that produced it was a cancer. Even if you, as a pathologist, can't recognize it as such, it must have been a cancer. And that's the sort of controversy that's been going on. So there are arguments for saying that this process isn't cancer. And again, there are, social issues here and insurance issues that we're not going to touch on, just purely what the pathologist argued. And they would say, well, I'm not going to call this cancer because I don't see that destructive invasion. I might see a herniation or a dissection or a perforation, but I don't see those destruction of the organ with glands proliferating through it. The tumor cells don't look malignant to me as a pathologist. Even though it does spread to the abdomen, it doesn't do what other cancers do. It doesn't spread to lymph nodes very often when it's low grade. And it doesn't spread outside the abdomen, especially if it's low grade. And that's usually with all this controversy is the low grade. There's less controversy with high grade. And then, of course, if it's low grade, the prognosis is much better than almost anybody who has true cancer that has spread to their abdomen. That usually is not a good prognostic thing. But this, half the people do pretty well for very long term. And so people would say the timing, the tempo of disease, the lack of progression in many patients doesn't warrant a diagnosis of cancer. But the other group comes back and says, no, no, no. The spread of tumor outside of an organ is cancer, and we should call this cancer. And then they argue some cancers can be bland. We know this from other organs in the body. Some cancers are bland. That doesn't mean they're not malignant. They're just bland cancers. And they also argue, of course, the biology of this, that pseudomyxoma can be fatal if not treated aggressively. And therefore, again, it's misleading to not call it some form of malignancy. So in 2003, I accidentally stepped into that fray because actually I had a case that I was a little confused by. I was younger, and I went to a more senior pathologist and I said, can I have help with this? And she helped me classify that tumor. And I said, I really don't understand this classification very well. And I said, maybe I should do a research project on it. And she goes, here you go. And she hands me 20 years worth of stuff that she hadn't been able to really sort together. And you're like, oh, okay. And it took me years to put that together. And finally, in 2003, published it. And working with several pathologists, we said, what are we going to call this? We'd like a name that doesn't depend on the circumstances. I can look at that appendix and I can give it a name, and it doesn't depend on whether it is spread or not spread. That will be a second issue. And we recognize the controversy. You can't call it adenoma because some people disagree with that. Can't call it cancer. Some people disagree with that. So we decided on actually a very non-committal term. It was actually the easy way out, to be honest. We decided to call it a neoplasm, a tumor. We're just not saying. We're just going to call it a low-grade appendiceal mucinous neoplasm. You can apply that to all of them, and then you can say, with spread, has it spread? Has it spread to the ovary? Has it spread beyond? And everyone should understand the biology of this. So we can at least talk the same language, and then everyone can start talking about, like, well, now what? What's the next part? And how far has it spread? And what's the implications of that? And maybe get away from trying to debate the semantics of is this or is this not cancer. In 2010, the World Health Organization actually adopted this term for this low-grade variant. So we end up with, well, I'll show you in a moment. So they ended up adopting this term for that low-grade variant, and again, to sort of avoid the controversy. But they did include it in their list of types of cancers. So while they included that terminology for these low-grade tumors that aren't quite invasive, and that seem to somehow rupture, they actually put it as a low-grade cancer. So in a way acknowledging that it's a low-grade malignancy, despite the term being maybe more acceptable to everybody. So this is a table, not, of course, one that we need to look at very carefully, but the point of this is to show you how there have been multiple classifications over the years, starting in 1995 from the Armed Forces Institute Pathology. In 2003, my publication, Stanford, published one in 2008, and finally in 2010, the World Health Organization. And you can see why there's been so much confusion in some of these areas, because if you had this a tumor at this level, you can see that everyone would have called it something different. Or if you had a tumor here, everyone would have called it something different. There aren't some controversies here, for instance. So if you had a tumor that was definitely invasive, everyone was going to call that an adenocarcinoma. So it was really the low-grade tumors that were causing the problem. And so you can see where the World Health Organization ended up, that if it's a tumor entirely confined to the center, to the lumen, and none of this crazy dissection stuff going on, we're going to call that benign. As soon as dissection or arms or tongues start to happen, we're going to call that a low-grade appendiceal mucinous neoplasm, even if it has spread outside of the appendix and you just have to then say it has. And then if it has this infiltrative type of destructive invasion, that's what we'll all call adenocarcinoma. Now, does everyone use this religiously? No, and that's what we found out at Basingstoke. So even at Basingstoke, they said, you know, what is your preferred terminology for these different levels? And there's better consensus, but not perfect consensus. And so you'll still see some people, well, I only like lamb for this situation and not for that situation. And so again, people are people, and it's sort of a matter of rallying everybody to sort of agree to the same diagnostic criteria. So in the end, I think in the last 15 years or so, we have begun to understand better the biology of this tumor. And as we give it a specific name, I think then we can begin to say, how is this different from invasive cancer? Is it different from invasive cancer? Is it different from colonic cancer? And so once something has a name, people can work with it. Because otherwise, if someone's reporting on something, I don't exactly know what they're talking about. And until we're all using the same terminology, because if I'm sort of saying to you, I'm thinking of a citrus fruit and it's orange and round, you'd say, I think he's talking about an orange, but I could be talking about a tangerine. And so we all need to talk the same language. And if I say banana, everyone knows what I'm talking about because there are no variants of that. But that's the sort of conflict we get into if we're not all speaking the same language. The clarity of the WHO will help in this situation, obviously, and as people accept that and adopt that. The meetings that already are beginning to happen, so the one at Basingstoke, the Peritoneal Surface Oncology Group International, those types of groups, these kinds of groups, bringing together consensus from all the pathologists. And still, much research needs to be done. In terms of standard pathology, I think we still need to look at what are the determinants that predict whether some people need surgery, will respond to surgery. And then, of course, as we move into the genetic age, we need to also start looking at the genetic events that will also predict how well people will do and whether they would benefit from such aggressive therapies or might they not benefit. And I thank you for your attention.
Thank you very much, Dr. Misdraji. That was a much-needed lecture for myself, I know for Dr. Sardi, and for anybody else who's interested in this problem. And you'll be able to join us after for the question and answer. So if people have questions, we'll have time at lunch for questions for Dr. Misdraji. I'm hoping that we don't need the boxing gloves in Amsterdam, but we'll see.
I got my pair.
Yeah. So I'd like to introduce the next speaker, Dr. Dale Greiner. Dr. Greiner is a PhD research professor here at the University of Massachusetts. He was recently awarded an endowed chair by Eileen and Stanley Berman specifically for research in appendiceal cancer. And So Dr. Greiner and I are looking forward to some collaborative efforts coming up here, and he's going to talk to you today about an incredible mouse model in which we can start to learn more about appendiceal cancer and hopefully develop a personalized treatment for people with appendiceal cancer. Dr. Greiner.
Yeah, thanks, Laura. I just want to say it's a privilege to be here with this group. I didn't know much about appendiceal cancer, and I'm on a steep learning curve right now, and Laura is a big benefit in terms of doing that. And I've been lucky enough now to team with Laura and the pathology group where we can actually start doing, setting up this model. So how do I get the slide started? There. It's on this screen. It's not on that screen. That's how. Laura, you fix everything, don't you? So I'm going to talk to you. I'm not going to really talk about appendiceal cancer, and I just hope you bear with me on this because I've really just started working with Laura and the group. And I'm going to tell you a little bit about how we're going to try and develop this program research-wise and what we've done for some other tumors in the past few years. And we're going to start applying these principles to appendiceal cancer here at UMass. So one of the things I think I want to impress upon you is that if you want to study human tumors, you need to study human tumors. You don't want to study mouse tumors, or you don't want to study... What? Okay, I will move this up a little. Sorry. And I'll make a lot of noise along the way. Okay, that didn't get up there. We will get here eventually, even if I have to look at the floor the whole time. Nope. Back up. Okay, that sounds like it did it. I just need to look down. So if I look down the whole time, please bear with me on this. So what we're trying to do is develop a model system where we can study human tumors in an in vivo environment, where we can look at how those tumors grow, what their characteristics are, and how we can treat those tumors without having to treat the patient per se to begin with. And what we are going to be using are immunodeficient mice that can be engrafted with functional human cells and tissues, including tumors. And I'll tell you a little bit about this and show you some examples. And what we want to do is use that as a preclinical bridge where we could take the tumor out of the individual, grow it up in 50 mice, study it, study how it's growing, study its response to various drugs, understand how it's developing, and then take those insights back to that person. And we're hoping to be able to develop what we call a personalized program for cancer therapy here on campus, where we can personalize tumor therapy to the tumor that's actually growing in the person. And I'll show you some examples of where we're getting there. So why do we need them? Because people aren't mice and mice aren't people. And we found in almost everything we've studied is that humans are not mice, and what we found in mice don't apply necessarily always to humans. And my 30 years of experience is in diabetes, and I'll just say we cured diabetes 30 years ago, but I still see a lot in mice, but I still see a lot of diabetics walking around on the face of this earth. So I decided about 20 years ago to start studying human tissues, human cells, and human immune responses rather than playing with mice per se on mouse biology. What it will do is allow us to study human-specific therapies. And in cancer biology, I just want to point out there's a lot of difference between a mouse and a human tumor. Structurally, you just heard a great talk about the structural differences, the function, the molecular characteristics, and how the pathology of those tumors. So they are not, human and mouse tumors are not identical. If we need to understand human tumors, we have to study human tumors. How did we get here? This started in my research program with other people, the discovery of an immunodeficient mouse back in 1983, and about 4 or 5 years later it was discovered you could grow human tissues in these mice. In 1995, a colleague of mine, Len Schultz, the Jackson Lab, and I published on this mouse, which the name is irrelevant, but we can now start studying a lot of tumors in mice that we couldn't study before 1995 in mice. But we still couldn't engraft a human immune system to be able to look at human immunity and tumor responses together. And then in 2005, we published this one, which I'm just going to call an NSG mouse. Forget all the nomenclature. It's an NSG mouse. I don't like the nomenclature either. Now, what made that NSG mouse so important to the study of being able to grow human tissues in mice? This is David the Bubble Boy, and people of my vintage probably remember David the Bubble Boy. He was born with a severe immunodeficiency disease back, God, forever. I don't even want to, I hit some laughter. I don't even want to remember how long ago this was. But it was a syndrome called X-linked severe combined immunodeficiency. And this is an immunodeficiency disease that really cripples your immune system to where it's almost non-functional. And this kid grew up in a bubble, a sterile bubble, till he was about 7 or 8. And at that time, they decided to do the wonderful thing, and that is give him a new immune system, and we're going to do it with a bone marrow transplant. Now, if they had been looking what was going on in the mouse, they would have realized that any kind of transplant of human cells from an EBV positive individual, which just about everybody in this room is, you were going to develop a B-cell lymphoma in the mice. Well, they did the bone marrow transplant with an EBV positive donor, and the poor kid, about 2 or 3 years later, developed an EBV lymphoma that killed him. In other words, if they would have listened to what was happening with the human cells in the mice, David would probably still be walking around on the face of the earth today. So the mouse studies of human cells in mice can predict or can be important for studying what's going on in human tissues. This is a picture of the little critter. It's a typical little white mouse. Looks like any little lab mouse out there. And it has defects in a lot of its own immunity. The skid prevents the development of an immune system, i.e. the one that produces antibodies when you're vaccinated. And this IL-2 receptor gamma chain, or that X-linked skid mutation, really causes a lot of the other defects in that immune system, to where this poor little critter has almost no immune system. And you can put any cell and tissue you want, from humans, from pigs, from dogs, from cats, you name it, you can grow those tissues and study their function in vivo. So how are we starting to use these mice for the study of human cancer? You can put the primary human tumors in, and you can see how fast they grow. And in melanomas, the rapidity and metastases of melanomas in these mice are mimicking what is happening with the primary tumor in the clinic. You can identify tumor stem cells, i.e. the cell that started this whole tumor in the first place, and I'll show you a little bit of an example on that with AML. You can use that tumor as testing various drugs to see how that tumor is going to respond to drugs without having to give the drugs to the patient to see how the patient is responding, the tumor's patient. You can study the metastases of how that tumor breaks, moves around, and we just heard a whole lecture on how important that metastases is in terms of the malignancy of the tumor, and you can study different therapies. What we hope to be able to do is personalize these mice with these tumors for personalized medicine in the future. So how do we actually do it? Depending on the tumor, you can put it in many different ways. In this one, you would be putting the appendiceal tumor into the peritoneal cavity to mimic what the tumor situation environment is in people. And we've been able to grow ovarian tumors, for example, in the peritoneal cavity, which is very similar to what happens in patients with ovarian tumor that have resisted drug therapy. So you can grow these tumors in the appropriate anatomical site to be able to look at how that tumor is growing and how it responds to tumor therapy. These are some of the primary tumors we've been successful in engrafting in the mice. I don't have appendiceal cancer on here because I haven't tried any yet, and we're working with Laurie now to be able to try and get some of these growing in the mice. And as they come along, we will be trying to get them engrafted. But basically, the bottom line is every human tumor, primary tumor we've tried to grow in these mice, we have been successful. So I anticipate we're going to be able to grow these appendiceal cancers in these mice to be able to study them. So what can we use them for? What we really want is to go after the cell that started this whole thing. And depending on the tumor, There can be, for example, melanoma. You can develop a melanoma from a single tumor cell. If you go back into acute myelogenous leukemia, you need a lot of the tumor cells to be able to develop the cancer. So this controversy, it's somatic, sort of like what you just heard in the nomenclature. Basically, what we're calling a stem cell is a cell that can regrow the whole tumor. And the frequency of those cells can be very high or very low, depending on the tumor that you're studying. But what we've been able to do is use these mice, or people have been able to use these mice, to identify the cell that initiates that whole tumor. Because if you don't take care of that cell in your therapy, the tumor will come back. And it's important to go after that cell, not just get rid of the bulk of the tumor, but go after the cell that will regrow the tumor if it's left in there. And I'm going to give you the example of how this was used by colleagues in Japan in these mice for acute myelogenous leukemia, which is a leukemia that affects kids. And so what you can do, it's one of the most common leukemias in the kids. This 5-year survival can be pretty atrocious for these kids, depending on it, and they have a high relapse rate. And so you'll be able to drive the tumor into remission fairly easily with standard drug therapies, but there's a high relapse rate because you haven't gotten rid of those cells that can regrow the whole tumor. So you want to go after those, quote, stem cells in this process. So what our colleague in Japan did was put these cells into the mice, and they grew a very nice, if you want to call a tumor nice, they grew the AML very easily in these mice, which was one of the first animal models of being able to grow human AML in an animal to be able to be studied. So what did they do? They looked at this and treated it with the standard therapy, Ara-C, and they were able to knock down the tumor in the mice very well, withdrew the treatment, and you saw the tumor come back. And if you look into the bone marrow of these mice, this little lining right here are the tumor cells after treatment that didn't get killed. This is what we're calling the tumor stem cell. They're still there after the traditional treatment. You take the drug away, these cells start proliferating, and they regrew the tumor in these mice. So what the drugs in this particular condition do is they target cells that are dividing. So you treat the tumor with a drug that kills dividing cells. You kill 99% of the tumor, but those cells that aren't dividing, that are hiding in the bone marrow, were not touched by that drug. So the investigators in Japan said, we're going to do something that's totally counterintuitive to treat a tumor that's proliferating. We're going to help it proliferate. So what they did was they induced proliferation of tumor cells, including those stem cells that were lining the bone marrow. They induced a proliferation, and then they hit them with the drugs, and then they looked to see if you killed all the cells, including those stem cells. And the answer was yes. They were able to cure that AML in the mice and prevent a recurrence by causing proliferation of the tumor before they treated it, rather than just going in and trying to kill the proliferating cells. Totally counterintuitive to everything that people have used to treat AML in the past. So they took it a step farther. Now that they knew what that stem cell population was that they had to treat, they went in and recovered those cells out of the mice. And then they did what's called a gene array profile. They looked at all the genes that are being expressed in those stem cells, those tumor stem cells, and compared them to a normal hematopoietic stem cell, a normal bone marrow stem cell, and looked at the differences in the genes in that. And they identified about 25 that were highly expressed in the tumor stem cell, but not expressed in a normal bone marrow stem cell. And this is just the version of what they got. Red means high, blue means low. These are the normal stem cells, and these are the tumor stem cells, and you see all sorts of genes that are upregulated or expressed in the tumor that aren't expressed in normal bone marrow. And they identified one, which is a HIT kinase in AML, and were able to find compounds, drugs, that targeted that specific kinase. And they were able to literally go in to these mice. They didn't survive, they weren't treated, treat them with this drug that they discovered by doing this, and really significantly reduced the ability of those cells to grow in the mice. This is now leading to a clinical trial in Japan. It was all based on modeling the primary human tumor in these mice, discovering why it was growing, discovering ways to prevent it to grow, looking at its gene expression profile, understanding what you might be able to go after as a target that wouldn't affect normal cells, testing it, and then bringing those drugs up and retesting them in the mice. This is a paradigm that we're going to be trying to set up for appendiceal cancer here on campus, is to be able to take the tumor out, grow it in the mice, understand how it responds to traditional therapy, find out why some tumors don't respond, and be able to see if we can come up with a combination of insights into those drug-resistant tumors that will lead us to an identification of a new drug or a new therapy for the tumor. I don't have any data on it. I can only show you what's been done with these mice with other tumors, but with the support of the Berman Foundation and the collaborations we've now set up with Laurie and the people on campus, we're going to be trying to move this paradigm into appendiceal cancer. Now, appendiceal cancer, you just saw a lot of pictures of the environment around the cancer. And that is, particularly when you have cancers like appendiceal cancer, which are solid tumors, the microenvironment that that tumor is growing in might have a lot to do with how that tumor grows. And there are probably environmental factors that the host, i.e. we provide, that are required for that tumor to grow. And then also you end up with immune cells as part of that milieu or part of that tumor complex. And you saw the former speaker pointing out the immune cells that were part of that. Why aren't those immune cells killing the tumor? That's what your immune system is supposed to be there doing, is protecting you from things like tumors. So what we're trying to do now, and this is a colon cancer that we're doing with an investigator on campus, Jean Marie Holton, who studies human colon cancers. We're growing colon cancers in these mice. And you can see that the tumor that we put in is very similar to the tumor in these NSG mice that we pull out after passage. So it looks like the tumor that came directly out of the patient. And we've done a lot of work with this colon cancer to show it is really very, very similar to the colon cancer that was grown in patients. But now we've got this growing in 20 or 30 or 50 mice where we can go in and study the growth and the characteristics of this colon cancer without worrying about harming the patient in the process. But what you can see is that the stroma, the extra environment, these are human cells that are supporting the human tumor in here, that as you passage these into new mice, you end up with just a tumor and none of those human supporting cells. So what we're going to start doing is we've developed a mouse, one of these NSG mice, that are green when you look at them. All you have to do is shine a fluorescent light on them and they pop up green. It's called green fluorescent protein. You can make these mice in any color you want anymore if you really want the truth. But what this is going to allow us to do is watch how the mouse environment moves into that human tumor. Now, you're saying, why do I really care about that? So what we can do is go back and genetically modify that mouse to take factor A or factor B or factor C away from that mouse cells and see if by removing factor A, the human tumor doesn't grow as well. And so we're going to start looking at how the host environment interacts with the tumor environment and how that tumor is dependent on the host for support of its growth. And we're hoping to identify not only things that are part of the tumor that are important, but part of the host that supports the growth of that tumor. So what can you do? This is just a typical thing. 5-fluorouracil is commonly used as a first order of defense against colon tumors. We put the primary colon tumor in the mice, and what we found is that we really just knocked the tumor out beautifully, just like it happens in humans. So this was just a proof of principle that you could use a drug that's used to treat people is the same drug that can kill the primary tumor in the mouse. Now, killing the primary tumor with standard therapy is not the most important thing in our life right now. What we're most interested in is recurrence of the tumor when it comes back and it's now drug resistant. we can put that drug-resistant tumor in these mice and now start testing different drugs at random to see if any of those other drugs that would not be standard therapy for a drug-resistant tumor is able to kill the tumor in the mouse. So this is where we're trying to go. We're trying to take the tumor, put it in mice. We can expand it at will so that by the second generation we could have 1,000 mice with that tumor growing, which means you could test 1,000 different therapies without worrying about harming the individual. And that's the first line of thinking we're going to be trying to do here at UMass on appendiceal cancer. Get it growing, line up 50 or 100 mice, see if various combinations of drugs are effective on the tumor, and then go from there, particularly in tumors that are now drug resistant. But what we're really interested in is not just using drugs, but trying to understand why your immune system didn't reject or take care of that tumor in the first place. And so what we can do, or trying to do now, is trying to learn how to model tumor immunotherapy in these mice. Now, these mice are very immunodeficient, and not only can we engraft them with tumors, but we can engraft them with human immune systems, so that 90% of the blood circulating in this mouse can be a human immune system rather than a mouse. So we could actually look at how a human immune system interacts with the human tumor in these mice. And we can line up 50 or 100 or 200 of these mice and study that interaction between the immune system and the tumor and try and figure out how to activate the immune system to do what it should have done in the first place, and that's reject the tumor. So how do you get these mice engrafted with human immune cells? I'm going to just show you examples of two. One is hematopoietic stem cells, like bone marrow stem cells. The other is with peripheral blood leukocytes. They're sort of different. One is we just take the blood out of you, we can put it in the mouse and say, do the immune cells in your blood target and kill the tumor? Because they should. And clearly they haven't been doing it. Why is the tumor resistant to killing? The other is to be able to put the stem cells in there so we can look at all components of the immune system and how they're interacting with the tumor. So just a couple quick examples. If you put the PBLs in the mice, this is just a proof of principle. Put a human skin graft on the mice, it heals in, you've got a nice epithelium, you've got nice dermal, you've got wonderful vascularization of the human. So this is just showing you can put a human skin graft on a surrogate for a tumor right now. If you put PBLs in that are from a different individual, you totally reject that skin graft. Now, if that works on a skin graft, why won't it work on a tumor? And we're hoping to be able to find that out here in the future. So the problem with this, and this is where you come back to playing games with the mice that you can do, is when you put the human cells in the mice, not only do they attack the human skin, which is different, they attack the mouse. That's different. That's a foreign tissue too. And you end up with a mouse after about 6 or 8 weeks that's basically on its deathbed. So you have about 4 weeks to study that interaction of blood cells with the tissue before the blood cells start killing the mouse. We've been able to figure out why those blood cells are killing the mice, and that's because of what's called major histocompatibility antigens. It's a reason I can't give one of you my kidney, because you're going to reject it. Those are called MHC antigens, is the main target of your immune system against my kidney. But in the mice, we can go knock those antigens or those proteins out to where I could give you my kidney without those proteins on the surface, and you're really going to have trouble rejecting my kidney because the main target of your immune system is gone. So that's what we've done with the mice, and we can now put PBLs or blood cells into these mice and have them function long term with very little reactivity against the mouse. So that means we can now study blood cells against tumors for 2 or 3 months without worrying about them killing the mouse host. I'm just using these as examples to show you can go in and genetically manipulate these mice all you want, from turning them green to removing gene expression in them, whatever you want to do. If you put in human hematopoietic cells or bone marrow stem cells, you can generate all the lineages of the hematopoietic system, including the T cells and B cells that comprise your adaptive immune system that are activated when you get vaccinated, and those are the cells that normally would reject your tumor. Again, you throw human skin on there, it heals in beautifully, put them on mice that have that stem cell engrafted, derived human immune system rejects them. We can now study the whole hematopoietic blood immune response and its interaction with the tumor in these mice, and that's what we're going to be trying to develop. So where do you really want to go on this? And that is, I don't think too many people that are undergoing tumor therapy really want to be giving up their bone marrow stem cells to be playing games like this in the lab either. It might be successful, but I don't think you're going to want to have those people standing up and donating bone marrow every 3 or 4 months to set up a new experiment to see how all this works. We're working with people at the Harvard Stem Cell Institute where you can take a skin biopsy of a person so that we could get the tumor out of the person and take a skin biopsy of that person and put it back into what are called induced pluripotent stem cells, i.e. stem cells that have the ability to develop into any other cell tissue in the body. You can take those stem cells that come from the person that had the tumor, drive them into thymic epithelial cells and bone marrow stem cells. The bone marrow stem cells populate the bone marrow of the mouse, go to the thymus where they're educated to recognize foreign things, and you can put them all back in this mouse, this NSG mouse. This is a nude NSG mouse, which has no hair, so it's easier to see tumor growth in these mice, and model the patient's immune response against their own tumor in this system. So that's where we're trying to go to long term. What I think we can do right now is get the tumor growing in multiple mice, to work with Laura and the other people to try various drugs on that tumor in mice. Then we're going to try and combine that perhaps with the blood, which is easy to get, to see how your blood cells interact with that tumor. And then finally move into where we can put the complete human immune system from the donor of the tumor into these mice and look out at how your whole immune system interacts with your own tumor and what it takes to activate your immune system to be able to take care of the tumor. That's a little longer project, but I just wanted to give you an idea of what we're going to be trying to do with a focus on appendiceal cancer over the next few years. So the story is basically we want to be able to personalize every cancer out there in these mice to where we can give you personalized advice on what might be effective against your tumor, whatever flavor it is, and be able to come up with a rational plan and not just guess how to treat the tumor, but actually have a rational piece of preclinical evidence saying this is probably going to work. This has actually been tried at a program at Johns Hopkins. Out of the 17 patients they treated, they found therapies that would have never been predicted to treat tumors in drug-resistant tumors on 14 of those 17 patients, which they took back to the patients, and they responded well to those therapies that were not predicted. That's the kind of program we're aiming to set up here with the mice. There's a lot of people involved with this. I just want to say thank you for the opportunity of allowing me to come over here and tell you a little bit about what we're going to be trying to do over the next few years, particularly with the study on appendiceal cancer, what we've done with these mice in the past, and what we hope these humanized mice will allow us to use as a preclinical bridge for trials of therapies on a patient-specific tumor approach. Thanks.
Thank you, Dr. Greiner, for trying to explain a very complicated concept in a very easy-to-understand way. That was terrific, and clearly the future of cancer care and appendiceal cancer here at UMass. And our next speaker, we're going to change gears significantly now. Our next speaker is Dr. Mary Sullivan, who many of you know is the nurse practitioner in surgical oncology here, and just an incredible resource, mentor, and friend who's going to speak to us today about exercise.
Good morning. Dr. Lambert's right. I'm totally changing gears. I can't make mice. I can't tell you pathology. I cannot make mice. I cannot tell you pathology. But what I can do, let's try to move this up so you can hear me. Is that better? No. How about that? I'll just hold it. Is this better? Okay. The things that we can do to help yourself in any of these journeys or to prevent yourself from having the journey, and that is discussing exercise and cancer. They've both been around for multiple centuries. The Greeks were the ones who named and made contributions to both. The Greek term for cancer is karkinos, and Hippocrates back in 460 BC equated the two and said it's very injurious to health to take in more food than the constitution will bear, when at the same time one uses no exercise to carry off this excess. For as aliment fills and exercise empties the body, the result of an exact equipoise between them must be to leave the body in the same state they found it, that is perfect health. This is still sounding funny to me. Are you hearing this okay? Okay. Use the hammer? Sure. Is this one on? Sorry, Luigi. So I just wanted to start with some cancer facts. What? Stand right here? Okay, can you hear that? In 1999, cancer replaced heart disease as the leading killer of men and women in this country who are 85 or younger. Heart disease has returned to #1, but there's only a 20,000 person difference. Between 1990 and 2007, we made progress in some cancers, and cancer deaths decreased by 22% in men and 13% in women, but still 1 in 4 were dying. Due to the advances in direction and treatment, now 65% of people diagnosed will live more than 5 years. That translates to 12 million survivors now, long-term survivors. Anyone diagnosed with cancer from the moment of treatment is now considered a survivor with the new paradigm. But it will be up to about 20 million by the year 20,000. That's roughly 4 out of 100 Americans will be survivors. So what can we do? Genetics, we've heard some about this morning. That's the basic building block of the cell. That's where our DNA is. That's your heredity that you get from your parents. You can't control that. We can't change that. Epigenetics is what we do to influence the cells. That we do have some control over. And there have been lots of studies done that glucose restriction in our diet extends the life of cells, and it reduces the survival of precancerous cells. So watching what we eat is one thing that we can do. But the way that cells multiply is to replicate and become what we call daughter cells. The longer we live, the more daughter cells we have, the more inflammation we are at risk for, and the more damage that it can accumulate, which sets the cell up to be able to convert to a cancer cell. Exercise is one of the things that can extend the life of the cell. So there are 2 things that we can influence, nutrition and exercise. Today I'm just going to talk about exercise. Prior to 2000, there was very little research, very few articles, less than 60 published on diet and exercise in cancer. In the last decade, it has completely exploded. There are over 45,000 articles on calorie intake or reducing, controlling the vegetables and the fruits and reducing the carbohydrates and the sugars. There are 15,000 on physical activity in cancer, its progression and recurrence, and 14,000 articles published on obesity. This year, the National Comprehensive Cancer Network, which is one of the international groups that our cancer physicians use to set guidelines for standard of care, published their first ever guidelines on exercise. They came out in March. The caveats are that all patients should be encouraged to be as physically active and return to daily activities as soon as possible. They're now saying during treatment there's a lot of data to support that. Physical activity should be tailored to what your individual abilities and preferences are. And I think the preference piece is the most important piece here, because the honest truth is, if it's an exercise that's recommended and you do not like to do it, or you find it hard, you will not do it. So you need to find a routine that works for you. The general recommendations are specific to exercise. The volume of weekly activity should be 150 minutes of moderate intensity. That translates to 30 minutes of brisk walking 5 days a week. 2 to 3 sessions of strength training that include your major muscle groups, and stretching those major muscle groups on the days that other exercises are performed. Now, this is a busy slide, but on the left, it's a list of what all the major muscle groups are. They really are the muscles in the front and back of your arm, in your back, in your stomach, although we can't really stretch those, and I'll talk about that a little bit more, and the large muscles in our legs. But that just you can get this just by Googling major muscle groups on the internet, and in the right-hand columns, you can see which exercises you should do. Despite all of those recommendations, the last time that this was measured was published in the Journal of Clinical Oncology in 2008. This is a slide of the proportion of cancer survivors who are meeting just the 150 minutes of walking weekly, and you can see it's less than a third. Because appendiceal cancer is on the lower number of measured cancers, there aren't specific numbers for them. So when I'm looking at this information and sharing with patients, I correlate with with colon, that the largest databases are out there in breast and prostate because that's where the largest number of survivors are. So what's the magic of exercise? What can it do for you? It can improve the way you look by toning things, and for those of us that cosmesis matters, it's important. But most importantly, it can strengthen muscles, improve your flexibility, and make your everyday tasks easier. It can increase strength and endurance. It can help to regulate bodily functions. Walking around and being mobile is one of the only things that you can do to help your body control constipation in addition to liquids and medicines that we use. It can reduce stress by releasing endorphins. It can lower the heart rate and the blood pressure. The endorphins that are released during exercise also help us manage pain. It can boost our brain power, and I have a study that shows some of that. It can enhance our immune system's ability to kill cancer cells, and it can improve fatigue, which is one of the key things for me, because most of our patients experience chemotherapy at some point in their journey, and the fatigue that persists after chemotherapy can be lifelong. It leads to a decrease in function, a decrease of activity, and weight gain, which is one of the factors that predisposes you for recurrence or secondary cancers. So what is it anyway? Wikipedia, or everything on the internet is true, is any bodily activity that enhances and maintains physical fitness and overall health and wellness. There are 4 types of exercise. Transportation, which would be getting yourself to and from work, walking to and from cars. I suppose it could be using skateboards, those kinds of things. Household would be the activities you do at home, washing, sweeping, carrying your laundry, cleaning, those types of things. Occupational, the activities that you do at work, involved in your job, and recreational would be the things that we do for fun, biking, kayaking, hiking, those kinds of things. Occupational has become much more sedentary. One of the conferences that I actually just came back from that I go to every year is the American Institute of Cancer Research. And it's an international group. Their focus is on diet, exercise, and prevention. And it's amazing the studies that come out of there. And 2 years ago when I went, one of the big changes that came up is that the average American sits 70% of their day. Because of the onset of technology and the fact that so many of us now use computers for our job instead of what we were doing, the average American has a 40-minute commute to work where you're sitting on a bus or train in your car. Then you go and walk into your office and you sit there for 4 hours, and then you have a lunch break where you go and sit with your friends and have lunch, and then you go back and do your afternoon session. Then you do your 40-minute commute at home, and the average American watches between 4 and 5 hours of television in the evening. What the studies that came out at that conference showed, it was a gentleman from Australia, is that just even standing some of that time, so instead of sending an email, go and talk with the person 3 cubes down, it increases your weight bearing, it decreases your osteoporosis, it increases the calorie burn and the oxygenation to your cells. Why does that matter to me? We know from other studies that bed rest, which most of my high-PEC patients aren't on bed rest, but they're not up much in the first week after surgery. It increases body fat mass, which changes our insulin resistance. It changes our triglycerides. It increases our blood pressure. And exercise reverses all of these. This is a study that they had presented. The AICR was canceled last year when Hurricane Sandy came through, and I was dying to hear the results of this study because in 2011 they had presented all the sedentary behavior information, and at the NIH there was a grant that came in that 244 people were going to be provided with sit-to-stand workstations. And this is what a sit-to-stand workstation is. Your computer's attached to something that you can sit at your desk and work, and you can just raise it up and stand at your desk. And they were given guidelines of how often to stand every hour. They did it in 3 phases. In the first phase, they just had all of the employees that were enrolled in the study document how much time they sat, what their mood was, what their back pain and neck pain situations were, what their weights were, what their powers of concentration were. They installed the equipment, had people track what they were doing, and at that point, they remeasured everything. There were significant improvements in people's mood, in their energy. They felt their concentration was better. People said they were more productive. There was a reduction in neck and back pain. There was no change in weight. And when the interesting and sad piece to me of the final part of the study, when they removed the workstations, people reverted back to their old behaviors and everything came back. There were very few people that reported that without a mechanism that they could do this, that they just continued to stand and continued to increase that weight bearing. Exercise prevention. 18 to 67% of patients can reduce their risk of dying of cancer with just regular exercise. There's a lot of, Dr. Meyerhart and his group demonstrated a lot in Boston that breast cancer patients and colon cancer patients do better with their treatment if they exercise even as much as they can during chemotherapy, and their time to recurrence is longer when they exercise regularly. Cancer survivors that are higher risk of dying from cardiovascular disease than those without cancer and exercise reverses that as well. This is the AICR, which I've talked about, does estimates of the preventability of certain cancers by a combination of the right nutrition, the right amount of food, fatness, and exercise. And you can see, I put the red box around the United States. That so again, because Appendiceal hasn't made it yet, it's 24% for all cancers, but look at colorectal is 45%. So though I know we've seen some of the differences, that it isn't the same disease, but it is in the same part of the body. And so if we can affect the oxygenation, then maybe we can make a difference. So what kinds of exercise? There are 3 types of exercise that we talk about. Strength training, or weight or resistance training. You can use small weights and resistant bands. You can use soup cans. How do you do it? 2 or 3 times a week, and you can start. I have our post-op patients just start with 2 or 3 repetitions. You should use those same large muscles, the upper arm, the back, the legs. You can just even do it by using your own body weight to squat. Start with 5 minutes every other day and increase each week as you can. Stamina is endurance training. That's aerobic activity, which helps the heart and lungs by increasing the oxygen in your lungs. We're going to aim for aerobic activity, and that brisk walking 5 to 7 times a week for 30 minutes is included. Biking, hiking uphill, race walking, martial arts. They say a treadmill, it needs to be 3 miles an hour. Zumba counts. And flexibility is the stretching. It keeps your muscles from getting stiff and helps to maintain or improve upper and lower extremity dexterity. So the mnemonic we use for exercise is FIT: frequency, intensity, time, and type. Frequency would be how often, and again, I keep repeating so that it sinks in. 30 minutes of brisk activity 5 times a week. Intensity is how difficult it is, and how you can tell. For some of our post-operative patients, just even walking in the beginning can be a higher level of intensity. And how you tell that is when you're starting to do these activities. If you can sing while you're doing it, that's a light activity. If you can talk but you can't sing, that's a moderate activity. If you need to take a few breaths before you can even speak, that's a vigorous activity. And that's how, though if you look at all the textbooks or online, it will identify specific activities. During the cancer trajectory, when you're in active treatment, what normally is a mild activity for you may be a vigorous activity. I always tell our patients that the walking piece is key. The other thing that studies have shown is that you can break that into 3 10-minute segments and still have the same effect on your body. The patients that are in the audience will know that I will remember that I always say this. I say, but I live in the real world. You know, in my own life, if my workout doesn't happen before I come to work, it just doesn't happen because I don't have those breaks. I have one patient that the setup of his job, he goes in 10 minutes early and can walk a mile around the building. He does that for 10 minutes in the morning. He does it at lunch. He does it before he returns home. For our post-operative patients, I ask them to do the same thing in 3 sessions, and believe it or not, I start them with 1 minute. If once you get home now, I want you to take 1 minute and without stopping, just walk circles in your house and increase by 1 minute each session, each day, till you're up to 10 minutes. This, again, are the NCCN guidelines and strategies to increase physical activity. There have been significant studies performed that show that if a physician actually writes a prescription, people will comply. People do what their doctor wants them to do. If you write a prescription to exercise, people will do it. And the NCCN went so far, it's in the guidelines that they suggest that you write a prescription for the patient to walk for 5 minutes. And as they improve and you see them, increase what you're writing in the prescription. Supervised exercise programs or classes are also helpful. Telephone counseling is something that we're looking at, motivational interviewing. And one of the things that we need to do is evaluate a patient's readiness to change. There are loads of cancer survivor-specific print materials. There are some from the American Cancer Society at the back table. Those are sheets that I give out to our patients. And as I tell my patients now that it's in the Worcester area, everything Lance Armstrong did wasn't wrong. He developed the Livestrong at the Y program, and if you're not familiar with it, you can check your local Ys, you can Google it, but it is a program where a cancer survivor and someone can accompany them, so a spouse or a friend, can be part of a specific program at the Y where you get to work 12 weeks with a personal trainer who will design the program for you so that if you have a bad knee or if you have some other ailment, they will work with the machinery, with the pools to help you get back in shape. They do work then afterwards to try to help you obtain or maintain a Y membership. Now that I've looked into it, I am aware they're very expensive, so I always use whatever I have at hand, and what I do is I send the patients there for 12 weeks and say, okay, so go learn the exercise program, and then you can go join Planet Fitness for $10 a month. It works. Dr. Lambert had asked me to talk about our exercise intervention study. In working with Dr. Lambert and HIPEC patients, and we had a period where we had a very high population of very young patients who were athletes. And they found when you have, those of you that have had the surgery or when you see Dr. Seide's presentation, these patients end up with a 10 or 12-inch monster belly cut that goes through all the abdominal muscles. So there are a lot of physical restrictions in the first 12 weeks after abdominal surgery. You're not allowed to lift, you're not allowed to do a lot of activities. And our young athletic patients, one in particular, was really distressed by the fact that he could not do all of his triathlete type of behaviors. And we have the great advantage of having a personal trainer who volunteers with us we do a GI cancer support group, and he's in the room today. And he became involved feeling bad and spent some time with our patients to figure out a way that we could develop an exercise program that spared those abdominal muscles. And he managed to do it with resistant bands, and we have actually developed a booklet in bands that we give to patients. Because it was so successful with these few patients, Dr. Lambert and I and Joe Glover, who's the personal trainer, actually presented it at the peritoneal surface malignancy program in Palm Springs in February. And if you're in medicine, you can't just do anything incidental like that. Everybody wants hard data of how it works. So we have now come back and are designing what's called a feasibility pilot. A pilot study is a small study where you test what you think to see if it can work. The feasibility piece is it possible for us to do? So we have now obtained a small grant to do it, and we're almost through the IRB process to initiate it. The plan will be to have 20 subjects in each arm. And what we want to do is evaluate the effects of this post-operative exercise program on patients undergoing abdominal cancer surgery. We're going to look at physical function, some activity measures, depression scores, pain scores. There is, when I first started the research for this, there was not much data out there. In the interim, There have been 2 articles published. Dr. Meyerhart from Dana-Farber collaborated with a group in Japan where they actually brought exercise bikes to the patient's bedside and put them on them for 3 minutes, 3 times a day. What they were looking at in colon surgery is return of bowel function, because as I tell patients all the time, once you've had belly surgery, and I always say when the surgeon touches the belly, nothing wakes up, and the intestine dilates, the only thing that you can physically do to change that is to walk. When you walk, gravity helps the gut to peristalse and things to move through. So it's part of the reason that we're looking to see if we do some of these activities, will people feel better sooner after surgery? So this is what a study schema looks like. And you can see on the far left, a new patient will come and we will randomize them. They will either get the intervention or not get the intervention. It's done by the flip of a coin. The chart's already there. The people that will go through the usual care will go through all the same measurements that we're going to do, some self-reported fitness, some that I will measure about what their actual fitness is, and I'll show you one of the tests. And then we will repeat some of those measures each time they come in after surgery. Normally after this surgery, someone is seen 2 weeks after surgery, somewhere between 4 and 6. And 10 to 12 weeks is our stop point, because that's the point that we lift all the abdominal restrictions and people can go back to their old exercise regimens. In the people that will get the intervention, they will meet with Joe, they will get the booklet, they will get the exercise band, they will get a personal instruction by Joe so that he is comfortable that they are able to complete the exercise program, and they will be given days of the week that they're supposed to do it. As they come back each time, I will make contact with them before they come. If they feel they need a refresher or they want Joe to go over something with them, then he will come to clinic and meet with them at the subsequent visits, and we will measure all of the same things we measured before surgery, after surgery. This is one of there are lots of studies out there. I worked with my physical therapy colleagues on this, that one of the measures of lower leg stamina and endurance, which are some of the largest muscles in the body, are the sit-to-stand measure. And this is something where you just have someone, so you can all go home and try it and see what shape you're in. Because what you do is sit in a chair and you don't use your arms. You cross your arms over your chest and you just use your legs to stand up. And it's timed depending on what you're doing, whether it's a timed up and go, just how long it takes you to stand. That's what we do with someone over 65. Under 65, we time how many times you can go up and down in the chair in 30 seconds. The other one is a 6-minute walk test. I didn't put the pictures of that up where you, will be the beauty of our new building, because we have that big long corridor with the glass windows, so I can set up and measure how long. You just have people get up from the chair and measure how far they walk at what they consider a brisk pace for 6 minutes. I think since we're short on time, we'll do questions later.
Thanks, Mary. That was great. And it's actually a perfect segue into our next presentation. Next, we're going to hear from... Yeah, I don't know. Here you go. From a wonderful lady. There's just words don't come to mind to describe Kerri Murphy. She is a person who's living with appendiceal cancer. She's a patient of mine, and Dr. Vina Bathini and Dr. Mary Lopresti. And she owns her own gym. She teaches spinning classes. She is an exercise fanatic. So as you can imagine, after surgery, it was a challenge to keep her from doing too much exercise. I don't know if there's such a thing in her opinion, but I'm going to let her share her story with you, and I think as you hear it, you'll just get a sense of what an incredibly inspirational person she is. Just a privilege for me to have gotten to know her.
Thank you. Okay, I don't know which microphone. Oh, hi! Thank you. Just let me know, is this mic good for, can you hear me in the back? Okay, I'm just looking at who showed up when my back was facing the other way. Thank you so much. Anyway, my name is Kerri Murphy, and it's funny that I just followed Mary Sullivan. I do own a gym, and I have had surgeries through Dr. Lambert, and just that exercise after, I mean, are you guys tired of sitting yet? Is anyone like so tired of sitting? Because I was like, oh, I don't know if you can see me over there, I'm rubbing my back, but just to sit for this amount of time is too much for me. So I did have surgeries. I did not get to get hooked up to the machine, the scary machine over there, but after all my surgeries, that's all I wanted to do was get moving, get moving, get moving. This table right here is my family. So this is supposed to be, this is my family caregiver, and this segment is patient and family perspective. So I've given them all the option, if any of them, no, they don't want to say anything. They don't want to say anything. So, but if they decide that they want to say something, they can come up and speak as well. But so after my surgery, just to follow up with the exercise, I did try to take it easy. I had my little pillow pet. It was like a cow pillow pet. Held it over my incision, was in my gym, walking on the treadmill, just trying to get things moving. And it just made me heal so much faster, I think, every time. I don't know, 3 surgeries? 3 surgeries? Big surgeries. So, but I did get carried away one time, so I do have a hernia, which I should have listened. I get a little too carried away. I wanted to get those abs back, wanted to get them back, but anyway, so I do have a hernia, so you do have to be careful with the exercise, what you do choose, and I think Mary Sullivan's got some great guidelines. I don't even know where she went. She's still here, so just listen to what she tells you to do, and easy on the abs. So I'm going to try to be quick because I see that there's lunch out, and I'll just give you a brief. I'm on chemo, and I have the side effect is sometimes weird voice, so sometimes my voice gets a little weird. But my story, I was diagnosed with Appendiceal last April. Well, actually, I was diagnosed with cancer. They had no idea. I was the cancer mystery. First symptom, I was at my gym with Carol Ann, back here in orange. She went, and we were doing it, we were just working out, regular day, and I'm thin. So anyway, since I don't have any body fat, on me, we're lying on our belly, doing some exercise, and I'm like, oh, geez, there's a rock. I thought there was like a pebble under the mat, like my yoga mat that I was on, and I said, I'll finish out the class. I'll get the pebble picked up later on, whatever. So every time we did the back extension, I'm like, oh, that rock. I'm trying to get it out, could not get the rock out. Turns out there was no rock. There was something, I'm looking for it, I'm looking under my shirt, and I'm like, Carol Ann, because she's a nurse. And I said, feel my belly. And she's like, I don't know. Oh. I do have gum. My mother's probably mortified, but my mouth will get way too dry if I take my gum out. So I did that on purpose. So my family can give me a little. If I start chomping like that, it's just to keep my mouth moist. So anyway, we found a little. Carolyn felt that. I'm like, what should I do? What should I do? And she's like, well, she's so sweet. She doesn't want anybody to worry. I would call the doctor. So, of course, I called the doctor, OBGYN, because it was like below my belly button. And she got me in, I don't know, the next day. It was so fast. Did an internal, and I had just, a quick note here. I had just had my OBGYN, like in February. I had full physical in February, and a life insurance exam in February. I get the lowest rate because I'm going to live forever, right? Because there's nothing wrong with me. It was just fabulous. Oh, hi, Deb. I just saw you. And so here I am, the healthiest girl, owns the local gym. I went in, and she said, the gynecologist said, I just met with you. There was nothing. Everything was clean. She tried again. She did another internal. She's like, oh, that feels a little strange. And I think it was that same day, ultrasound. Let's just do an ultrasound. So we go in. Carolyn is with me. I do the ultrasound. And the tech's saying, oh, look at all your fibroids. And I was like, I don't have fibroids. I've never had fibroids. So they were on the screen, I don't know, we saw like 4 or 5 little fibroids over here, and then we saw the big black, this big, I go, well, what's the big black thing? I think it's a fibroid. And I'm like, oh, all right. So we just, of course, I wanted it to be a fibroid because who really cares if you have fibroids? I don't, at this point, I wouldn't care. So anyway, they could not see one of my ovaries. So they said, we're going to CAT scan you just to, make sure, I don't know of what. So I think the next day was CAT scan. It was like boom, boom, boom. Within a week, I kind of knew what I had, I think. Well, not knew what I had. I knew I had cancer within a week. And remember the slideshow, which I didn't know I could have a slideshow. I would have had a slideshow of I don't know what, but of the big fat belly. Remember that big fat belly person that they showed? Mine was not that big and fat, but I'm telling you, I went from, I think when I was operated on, which was not Dr. Lambert, my first surgeon, because I had a gynecological surgeon, they said I was measuring about 5 months pregnant, so I'll remind you. And in 3 weeks, I was like, and I can remember going to like an MRI or something. We were at one of the hospitals. It was not UMass, and I was walking with my boyfriend Dan, and I remember a woman said, "Are you looking for prenatal?" I was like, "No." So I was like waddling, so there was something obviously growing quickly, not a baby. So we had the surgery done by Dr. Hughes because they knew, and I could not figure out what it was. There were spots in my liver, there was stuff everywhere. It was just, all I knew was that you've got something that's acting like cancer, but we don't know what type it is. We can't figure out where it's originating from, kind of because it was everywhere. So I remember going under, and I just said to Dr. Hughes, just get it out, because it was so gigantic. And I think she removed like a Nerf-sized tumor on one ovary, and then behind it, there was a grapefruit attached to the other. I'm like, I told you I was skinny, because she's like, oh, I don't know. So she removed all that, and I think during surgery, I don't know if she called Dr. Lambert, I don't know, they talked to each other while they operate, but she called and said, I don't know what is in her. And Dr. Lambert knew, I think, from the description that it was appendiceal. So I woke up. Can I have my water, Gil? I'm getting my dry mouth. It's not my medication. So I remember I woke up, and the nurse was at the end of my bed, and I said to her, I was, of course, I don't know whose head dilated before, but I said, do I have a uterus? And she's like, yes. And I was like, because I thought I was going to have a hysterectomy. And then I said, do I have a poop bag? Because before you go under, they have to draw, they take the blue marker. Where do you want to put your ostomy bag? I'm like, nowhere. But they draw a little line every time they draw, right? Where do you want to put it? I'm like, I don't. You got to, well, where do you wear your pants? And I'm like, well, I don't know, because now I'm 5 months pregnant, so they marked me for my bag. So I said, do I have a poop bag? And she said, no. And then she was kind of weird, and I'm like, okay, that's all I want to know. So anyway, then my next memory is like a parade of people, like whoever was there, my girlfriend, there were like, I don't know, 5 people. I can't remember, but I remember Carolyn, because I knew she was supposed to go, yay! And she didn't. She went, and I was like, oh. So, sorry, Carolyn. So she was the giveaway. But it was supposed to be, yay, it's benign. They didn't know what it was because it was nothing, but... And then I met Dr. Lambert, who was just awesome. She said, you have appendiceal. And I said, I have what? And she said, appendiceal cancer. And then I forgot, like 10 more times because I was on the drugs. But once it sunk in, she did say her best advice was do not look it up online. I mean, if you look up a cold online, you know that you're going to die anyway. So she's like, don't look it up. And I'm like, okay, I'm not going to look it up. And I didn't. I trusted everybody, didn't look it up. You know, and she had talk of, like, all those big words that we heard before that meant nothing to me. I know all of them now, but it turns out that I had the most aggressive. I do have the most aggressive. Sorry. I'm looking at people crying. They're making me cry. Most aggressive form, but look at me. Wait. So anyway, this has been like, I don't know, maybe since last April. So what is that, like 20 months? 20 months maybe? So we do the surgery, you know, with the gynecological surgeon. She took out the ovaries, the tubes. I don't even know what she took out, the appendix, obviously. And then they were going to put me on chemo, which I met my most awesome chemo doctors. In the back, orange. They had my shirt on, and they made me autograph it. Their shirts were autographed with my autograph. So anyway, so we started my chemo, which was, it wasn't that bad. I mean, I'm like, chemo's not that bad. Oh, at first, it's not that bad. I'm like, I don't think it's chemo. I think they're giving me water. I'm fine. So, you know, the more you get, I've been on chemo since last June, kind of nonstop, still on chemo. Except I skipped it today, but that's another story. So, and I won't tell you because we're going to have lunch, but because I know you want to eat. So we did the chemo, you know, and then you do your scans, you do your chemo, you do your scans. It's like a routine that you get into. Every 3 months I scan you, I check you, what do you look like, and you can't really see much of my cancer on a scan, which stinks because you want to see it so you know what's in there, but you can't really see. So a few times in between, like I was in the emergency room, I had a couple of ileus where my bowels stopped. I had, that liver, I had like my liver bled because they did a liver biopsy because I thought it was liver cancer. I was a regular on that 7th floor. Cindy's still back there. My 7th floor nurse, she's awesome. I lived up there. I was there for, I think, 40 days last summer. Not all together. It was broken up, but I think a total of 40. I knew all of them. So surgery. Then I had a bowel resection surgery, which was horrible. You think that would be nothing. I had all these tumors taken out of me. I mean, I had so much done that Dr. Lambert had done, and now they're just going to take out this little tiny, well, I don't know if it was tiny, I didn't really ask them, I didn't want to know, but to take out this little tumor that was obstructing my bowel. I'm like, well, that's fine, just do that. So, did you ever have the NG tube? Raise your hand. NG tube? You did? Yeah, it's bad. I had that time that I had the NG tube, it goes up your nose. While you're awake, they snake it up your nose, and then you swallow it down into your stomach, and then green bile comes out into a bucket, and then your visitors come and you have green bile, and you're like this. Okay, you look good. Like, I know I look really good. So, anyway, I had the NG tube that time for 15 days. I was going to kill anybody at that point after having that thing for 15 days, but Dr. Lambert went in, she did the bowel resection. It was successful, thank God. So I was able to go home and poop, which was really nice. But I remember on discharge from that surgery, you know, they weigh you all the time. And I got on the scale and it said 109. And I'm like, I don't weigh 109. And she's like, yeah, you do. I said, no, I weigh 130. She's like, no, you weigh. I was in such denial that I had lost that much weight. And I remember I went in the bathroom because I was not looking in the mirror. I mean, you're not looking real pretty in the Johnny. And I remember I took my Johnny off and I was like, oh, like bones sticking out. Oof, it's horrible. So on we go, scan. I think we did a scan. And then I looked all right, so she did the laparoscopic just to take a peek, because everything looked good on the scan. Did the laparoscopic, we couldn't see anything because I have a lot of scar tissue. So we were going to attempt that big baby over there, that machine, the high pack. it's a sad thing to say that it would be my dream to have that. But anyway, we couldn't have it. And I remember going under, where do you want the bag? So they had to draw the bag mark for me again. And she did say, you know, there's a good chance this is not going to be successful. Very often, I guess they cut you open and like, oh, we can't do it, you got too much cancer. And I can remember when I woke up from that one, like, you think you have no sense. I mean, you fall asleep, you're awake, right? Surgery is just boom, boom, boom. You don't know what's going on. But I knew, I opened my eyes and I went, I didn't have it. I knew I was only out for like 4 hours. And there's my boyfriend sitting in the corner. And I went like this. And he saw me and I said, I said, what time is it? Like that. And he said, oh, it's about noon. I was like, ah! You know, he should have had full body armor on because I could have killed him because I knew. So I had my little crying tantrum fit because I knew I couldn't have the high back, which was what we wanted. I think one big tantrum in the hospital, it was a bad one. And I get over it, and then Dr. Lambert came in, and she's so comforting. She made me feel all right with it, so sew me back up, back on the treadmill, back with the pillow pet. And I think that was my last surgery. That was last November. That was Dad's birthday. My family. So anyway, could not have that high back. But so on we go. We got to change the chemo because obviously the chemo didn't work. And I think I was thrilled to change the chemo because the chemo that I was on, I lost my hair. Like, it wasn't hair loss. Like, it was so gross. It was like, oh, I'm missing a whole patch right here. Oh, there's a patch right here. It was like, because I had kind of a lot, like hair to hair probably. I used to wear pigtails, but it was coming out, and it was called hair thinning. So, like, some chemo is hair loss and some is hair thinning. I'd rather have hair loss because hair thinning is so, oh. Anyway, we ended up shaving it off. And then also, with that chemo, I had the acne. Remember that, Mary? Oh, my God. She said, you might get a little acne. I'm like, oh, that's fine. I've had acne before. Oh, my God. I woke up one day, and I was like, oh, my God, I can't go anywhere. Like, I'm not exaggerating. 1,000 whiteheads. Like this. Bald. I'm like, oh, my God. I was the ugliest. Like, my 13-year-old, we just changed my chemo again, and he said to me, is this one going to make you ugly? He said that to me. And I said, no, I don't think so. I have a little rash, but it's not that bad. So kind of happy to switch the chemo, switch it to another chemo, dealt with that. That chemo did not work, we know, because I got this lump, which you can't, I'll show it to you, but I got this lump, and we couldn't figure out, what did she do to herself? Well, I did injure it, but I was carrying a bike, but that's another story. So I'm pretty independent, and I was bringing a bike up a set of stairs. So next CAT scan, I just knew that this was not from carrying a bicycle. It's in the bones. So now it's in my spine. It hurts. Wait, that looked really good. I still want to do my soul workout. So it's in the bones. It's in my spine. Two spots on the spine. One in my rib cage, which that's why I was sitting there squirming because I couldn't sit any longer. Collarbone, maybe a couple other spots, but I don't care whatever. So it did spread to my bone, which is so rare. So I have the rarest cancer, rarest everything. I get all the rare side effects. It's in my bones. I'm like, okay, I can take it. So, you kind of go one day at a time. And knowing, I think, that the chemo is just keeping me here, it's not going to make me better. I don't have a chance for that. It's kind of scary looking anyway, but just, to keep me alive. And they do such a good job. They do so well with me with the chemo and adjusting the dose, making sure that I can do things. But the last scan, which was recent, they found it in my lungs. I'm like, oh, God. And what was funny? It is kind of funny because I was teaching a spin class, because I teach, I think before cancer, I taught like 27 fitness classes a week, and now I teach like 6, something lame like that. So I think that's lame if you only, but anyway, so I was teaching my spin class. It was like a Monday night, and I said to them, I said, oh my God, because I'm pretty open about the whole thing. And I said, well, I have my scan results tomorrow. I said, at least we know it's not in my lungs, because I kick your ass on the spin bike every Monday night. And they're like, well, for sure. So anyway, I teach, and we go, and I'm like Susie Fitness, and I'm fine. And Dr. Lepresti comes in, and I knew, because she's got that face. She's like, you just know. And so we're sitting waiting for her, and she's always running by, because she's running, and she's running, and she's running, and she's busy, and she's busy. And she ran by, she goes, I'll be right back. And I went, something's wrong. I just knew from, I'll be right back. So she came in, and she said, well, so, the spine meds haven't changed. And there was a but, and I'm like, and she said, we did find some new lesions. And so I'm thinking, well, maybe on my hips or something, because my hips hurt sometimes. And I said, where? And she said, in your lungs. And I went, oh, both lungs. So I don't feel that. I think sometimes, like, it's psychological. Now when I try to breathe, I get like, oh yeah, I have cancer, I can't breathe. But I actually can. So it's all made up in my head. My bones hurt, but my lungs don't. So now we're on another chemo, which is a pill. It just keeps going. It just, you live and you scan, and then you try another chemo, and then you scan, and you keep going. But I didn't want to cry, because honestly, since I've gotten cancer, it's been the best, 20 months of my whole life. I mean, Tim can probably relate what cancer does to you. It changes everything. Like, people that maybe you didn't like before, I'm like, why didn't I like someone before? What did I complain about? When you're really busy, or if your kid's room is a mess, or, oh my God, those are such good things. They're such good things. Sorry, Mom. So, anyway, right now, we just live. I still own my business. I still work as much as I can. I come here all the time, and every time I come here, I have fun. I have every visit. Yesterday, I'm with Dr. Bathini and Dr. Lepresti, and I have a good time every single time I come here. Isn't that the strangest thing? Every time I see my doctors, I'm laughing, and I leave, and I'm laughing, and I realize that, they tried radiation, too, for some of the pain. And I realized, I'm over on that building for chemo, and now I'm over in this building, or wherever I am now, but I'm over there for radiation, and people in this building going, hey, Kerri, and I'm like, hey, and people in the elevator, Kerri, I'm like, oh my God, everybody knows me from this hospital, because I'm here so often. But it's just it changes your life to appreciate that every single day is awesome. There's nothing bad. There's nothing bad about any day. It's in my lungs, and what I do, that was my latest. I don't want them to scan this. I don't want that. I'm fine. I'm just from here to here. I'm covered. But so if they don't scan my head or my legs, that's fine, because it's everywhere else. Don't look at my arms either, because it might be one in my elbow. I don't care. But so I know it's everywhere, and I live with it every day. It hurts. The spine meds hurt, and I hate pain meds, but I have to live on them now. So that's a big fight. They fight with me all. Dr. Bathini is in a big fight with me all the time. See, he's laughing. He calls me Dr. Kerri because I change my medications and, things like that. But we're always in a fight. They just want to get me pain-free, happy, and I try so hard to just, I am doing what they say this time. This is the first time I'm like, I'm going to, because he's talking, he's going like this to Dr. Lepresti. She's not going to do it. I'm going to tell her she's not going to do it anyway. Kerri doesn't do what we say. And I'm going to do it this time. So this time, I'm taking the medication right when I'm supposed to. I'm going to live in pain for the rest of my life. I know that. But it's okay. It could be so much worse. If you think about, I know you want to eat lunch, but at least the people with cancer, or if you know someone who has cancer, you got like this long exit ramp, like you go in there, like some people, they leave their house, they get hit by a car that day, or you get in an accident, or you're killed at the mall or at school or whatever. You just have that happens all the time. You have no warning. But I get to go and just drive slow, and so you kind of get a whole different perspective on life and how to enjoy it. Just to go slow. Okay, thank you. Enjoy your lunch.
I told you she's amazing. So please, everybody, help yourself to lunch, and then afterwards we're going to hear another wonderful presentation by Laurie Todd, who has her own incredible story to tell involving both appendiceal cancer and all the advocacy she's done for people with appendiceal cancer and other rare conditions in getting insurance companies to help cover the costs of their health care that they desperately need. So please help yourself to lunch, and then we'll regroup for Laurie's presentation. Thanks.
Test, test, test. 1, 2, check. Just switched the actual other handheld one they were having issues with.
Oh, you switched this out?
Yeah, I switched. This is the one they were using.
Yeah. Do you want to try this one?
Check 1 2 test. Check 1 2 test 1 2 check. Check 1 2 test. Testing 1 2 check 1 2 test 1 2 check. Checking 1 2. Check 1 2 testing 1 2 check 1 2 checking 1 2 test 1 2 check 1 2 test 1 2 check 1 2 testing 1 2 test 1 2 check. This one's better. Check 1 2 check 1 2 testing 1 2 check 1 2 testing 1 2.
Phone's off. That's it's working. All right.
I'll sit down first.
So we're going to continue with the last segment of our program for today, and I'm going to welcome to the podium Ms. Laurie Todd, who also has the nickname of the Insurance Warrior. She is a, can't hear back there? She is a appendiceal cancer survivor herself. She may tell this as part of her story. She had a high PEC about 8 years ago now with Dr. Paul Sugarbaker, and unfortunately, as soon as she had her diagnosis, she ran into the issue of getting the insurance company to cover her surgery, and she was able to put together an appeal and get that approved by her insurance company. It's an incredible story. She has made this her life's mission to help people who are struggling with against their insurance companies to get approval for the care that they need. She has published 2 books and recently won her 131st appeal in helping people get their coverage. So I'll let Laurie tell the rest of the story.
How many here are patients? Your story is my story. In November of 2004, I went to see the primary care physician. I'd been feeling terrible for months, just exhausted, bone tired, and plus my abdomen was getting kind of bigger. So I went in to see the primary care. She did all kinds of blood tests. She did a physical exam. And she said, "You have nothing to worry about. You're the healthiest 55-year-old on the planet." 4 months later, I was being rushed into surgery and given months to live. Within a 3-week period, I was told, "You have stage 3 ovarian cancer. It's benign. You don't have cancer. You have appendix cancer. Pseudomyxoma peritonei." Because I had such a weird, unusual cancer, they sent me to the chief of oncology at my HMO. I got to see the chief. I sat down and he said, "You have 2 good years left." And I said, "Really? That's bad news." He said, "Yeah, it is." And I said, "Well, is there anything I can do? Is there any treatment?" He said, "There is no treatment for your disease. And even if there were, they wouldn't pay for it." To me, those words were like a red flag. It's like, I'll show you. I'll prove you wrong. I spent the weekend Googling. Unlike you, I went and started reading scientific articles. That's where I started. And by the end of the weekend, I'd found the surgeon who'd done the most of these surgeries, who had the best long-term published outcomes. And before you know it, I was borrowing frequent flyer miles and flying to Washington, D.C. to see him. By then, I'd lost my business. I had no income. But I borrowed frequent flyer miles from friends, and I traveled from Seattle to Washington, D.C. to have the consultation. He judged me to be a good surgical candidate. I went back to Seattle, and my HMO immediately denied it. They're an HMO. They had no intention of paying for any kind of Dr. Sugarbaker all the way across the country. I had a month and a half between the consultation and the surgery. So I figured, well, this is my job now. I spent days at the library, sitting on the floor, reading insurance law in the state of Washington. I read lawsuits against HMOs to see what kind of language they use. I went beating the bushes of patient groups to find people who'd had it paid for before, building my list of precedent. And I studied my insurance company. I read their entire website, press releases, news articles. They were my opponent. I needed to know them. Eventually, I wrote what I thought was a pretty long appeal. It was 23 pages. To me now, that seems short. And nobody thought I would win. Well, they made big crocodile tears. They said, well, I guess you'll just have to go to that doctor at the University of Washington who's done 6 of these. And nobody thought I would win. 3 days later, I got a call from the insurance company. Well, we decided to pay for it. I must have scared them really bad because they paid my deductible, too. My out-of-pocket, they paid all of it. My only out-of-pocket expense that year was $9. And being me, I called the hospital and I said, so, what's the $9 for? And they said, you asked for a glass of juice. And I said, well, I'm a big spender. I'll write you a check for $9. The entire bill, I believe, is $346,000 because I kind of hit the jackpot of complications and was in there for 43 days. So once again, in October of 2005, I got on another plane with my borrowed miles and went to Washington, D.C., where I had a 14-hour surgery with Dr. Sugarbaker, the HIPEC that we are so grateful for, and 5 days of intraperitoneal chemotherapy. That was October 2005. I've never needed any medical treatment since then. I'd probably been home about 5 or 6 weeks. I was still completely disasterized, kind of like the 100-year-old woman, sitting there in my PJs trying to figure out what to do with the rest of my life. And I got a call from Bob in Philadelphia. He was a friend from an online appendix cancer group. And he said, Laurie, we heard you had a great victory. My insurance company won't pay. Can you help me? He had Independence Blue Cross, Pennsylvania. I said, well, Bob, I don't know if what I did is going to work for you. However, I'm just sitting here in my pajamas, so let's give it a whirl. We cut, we pasted, we laughed, we cried, we bonded. 3 days later, I put something together for him. 3 days later, he called me. Laurie, they're going to pay. Now, it probably took me 2 years before I realized that this was my work. During that first year, I wrote, I think, 14 appeals, and I won them all over the country, all different insurance companies. And I thought, well, I really don't want to fight everybody else's battles, so why don't I just write all this down? Then I can give it to them, and they can do this for themselves. That was the first book, so it came to be. Because when I got done writing it all, I said, there is no book to help people. And it's a book. So I found a cancer foundation, wrote a grant proposal, and during 2006, then that was the year of the book project. And I still kept writing appeals. And after the book came out, people with other things found me because I knew that this doesn't just get denied because it's so-called rare. Things get denied because they're expensive. So eventually I had a little variety in my life. Now I'm writing appeals for brain surgery, organ transplants, deep brain stimulation for severe Tourette syndrome, craniofacial surgery for children. It's all the same strategies all the time. Sometimes I think I'm so successful at this because I have a high tolerance for the absurd. Because it's all absurd all the time. But I feel really how I do this and what's different about what I do is that I begin from the point that no appeal was ever meant to lead to an approval. No appeal. It's not a good faith process. It's an illusion of due process. If you comply with the insurance company's process and you supply everything they ask for, and you're a good little camper, You give them all the information they asked for, it's going in the shredder. They're not planning to pay for it no matter what you do. So if you start there, then there's a good chance you'll be successful. Now, many people don't think they're ever going to have a denial from their insurance company. But I have good insurance. They paid for my knee replacement. They never give me any trouble. Well, what I would say is that you're fortunate that you haven't come up against anything that they don't want to pay for yet. And I truly believe that every one of us in this room will come up against an insurance denial in our lifetimes. The average lifetime medical expenses right now for one person are about $38 million. You used to hear the word, figure $2 million lifetime maximum. That was computed in 1970. I've seen people run through $2 million in 6 months. So it doesn't add up. No insurance company, no government entity can really pay $38 million for everybody. It's a house of cards. It's a Ponzi scheme. So how do they manage to give you the idea that they're actually going to cover you and still not go broke? By having many hidden ways of not paying for things. And the most obvious way is by denying treatments, legitimate treatments, like cytoreductive surgery and IPEC. So in order to win these things, you kind of have to know, what are these denials really about? Why are they really denying them? The insurance company will tell you they need more information. Your doctor just needs to send us lots of information. Then we'll know how to pay for it. This is really not about information. All these insurance companies already know about your treatment. You know why? Because they've already paid for it hundreds of times before. They just hope you don't find out about it. Is it about science? They're denying it perhaps because there's not enough science? Well, I have news for you. Insurance companies routinely pay for treatments with no scientific basis whatsoever, and they routinely deny treatments which have a mountain of evidence to support them. Not about science. People think they're being really clever if they figure out that these denials are really about money. But they're not. I used to think they were too. But you know what? With every appeal I win, I save the insurance company thousands, if not millions of dollars. Look at me. I've saved my insurance company millions. They should give me a medal. But if it's not about money, what is it about? It's about control. Insurance companies have had 40 to 50 years to consolidate, refine their control over doctors and over patients. And the mechanism of that control is the network. You go where they take your insurance card. And the doctor who is in network is now bound by contract, whether or not he really likes it, to your insurance company. Therefore, your doctor's not ideally positioned to fight the insurance company. This is about control. It's a strategy game. And with my magnificent documents and all my other strategies, it's all meant to wrestle control back from the insurance company for I can do it for about 3 to 4 days. Just long enough to get them to pay for it before they know what hit them. It must be pretty successful. I haven't lost one of these things for years. I can't even remember the last time. But you have to know that it's really, it's really a strategy game. There's just one thing. If you just know one thing from my talk, you'll be the master of this insurance game. When an insurance company denies something, when they call something experimental, when they say it's not a covered benefit, when they give you a time limit, it's not the law. It didn't come down to Moses on the mountaintop. That's just what they say. People ask me, oh, how long do they get to decide my appeal? I say, however long you give them. You know, you're in control now. So just for your entertainment, I've given you a handout. It's the first 2 pages of an actual appeal here in the state of Massachusetts. I fought many appeals here. Harvard Pilgrim, Blue Cross Blue Shield of Massachusetts. You know, this is kind of like my territory here. So I'd like you to look at the bottom of the slide that says Table of Contents. We'll begin at the end. So how long is this appeal? Right here at the end. How many pages is it? 50. This is a 50-page document. Do I really expect them to read all 50 pages? They don't want to read any of this. This is an unsightly document. What I want, my strategy is to have the first page be so powerful, so compelling, so unsettling to the insurance company that they might just pay for it from this first page alone. Now, I'm going to tell you, even if you really believe that you're never going to have an insurance denial, this works for everything. This is a way to cut through a bureaucracy like a knife through butter. And I've used it against the government, the phone company. To give you a recent example, I ordered a desk and a filing cabinet from Office Max. And they told me it was going to be delivered on Tuesday. They didn't show up. I waited all day. I'm the insurance warrior. I'm not going to put up with that. So I went online and I found the highest level executives at the home office of Office Max. Their personal phone numbers, Google, and their personal email addresses, and a fax number. And I wrote a little one-page story about the runaround they'd given me. Guess what? My desk arrived by Federal Express the next day. It works for everything. What is the first thing that people do when they get denied a treatment? And it's always a life-saving treatment, by the way. First thing they do is call the insurance company. Well, I'm going to tell you, please put down the phone. I've never heard of any denial being reversed by talking to the insurance company on the phone. Neither you nor your doctor has access, would be allowed to talk to anybody at that insurance company who's a decision maker. So don't waste your breath, don't wear yourself out, put the phone down and put it in writing. And don't expect anyone else to do this for you. Somehow, from day one, I always felt that it was the surgeon's job to save my life, and it was my job to make it as easy as possible for him. In other words, to make my insurance company pay for it. So my approach is to do exactly the opposite of what the insurance company wants me to do. I want to upset their apple cart. I want to throw a wooden shoe into their machine. I want to throw them off their game. So where does the insurance company want me to send this masterpiece? They want me to send it to a post office box. No matter what insurance company it is, you always send your appeal to a post office box. Why? Right. You can't call a post office box on the phone. You can't march up and down in front of a post office box with a sign. They retain control. And so I do the opposite. The opposite would be to spend many hours. I'll spend 8 to 10 hours on my address list, sending a fax or an email to the top executive CEO at that insurance company, directly to his desk. Then I can often get his phone number, too, and we're going to call him on Monday. We'll send it on Sunday night so they don't turn off the fax machine. This is 50 pages. And then I have my person call him on Monday morning. Hi, Mr. Dreyfus. This is Jan Smith calling, just to see if you've received my urgent expedited appeal. Oh, great. How's it coming along? So, when can we expect a decision on that? Oh, well, I'll be checking back in a couple hours to see how it's coming along. In other words, I've got your phone number. You don't know how I got it. And I'm going to be calling you until you make a decision. That appeal number 131, I sent 14 copies of it out to these people on Sunday night, and we won it on Monday morning. You know, strangely enough, it works. People used to ask me, why do they ever pay for anything? Why do they ever approve these things? They don't have to. I used to try to come up with all kinds of explanations why. I don't work there. I don't know why. But finally, I just say, you know what? Because I'm smarter than they are. You know, period. So what is this powerful, compelling first page? It's merely a list of who I sent it to. This is Blue Cross Blue Shield of Massachusetts. Now, don't expect to find all these executives still there, 10 months later. They don't really last very long. You know, it's very stressful denying treatments all day long. But if you only send it to the CEO of the Blue Cross Blue Shield of Massachusetts, you aren't at the top of the food chain. First, you've got to know your insurance company. That's your opponent. Blue Cross Blue Shield is 39 different companies, but the top of the food chain is the Blue Cross Blue Shield Association in Chicago. What they say is they set policy for all the Blue Crosses and Blue Shields. That just tells me they have an influence. It also tells me that all these people at Blue Cross Blue Shield of Massachusetts will look at this and say, my boss got it. And all the people below them say, my boss's boss got it. I better do something about it. It's a synergistic effect. I call it poking the stick in the hornet's nest. When they all get this simultaneously on Monday morning, they start calling each other. What are we going to do? And that's action. Now, I'm not going to go through all of these, but you can look at them later and see, why did she pick that person? They're all very well hidden from us, you know. The last thing in the world these high executives want is to hear from the likes of us, which is the perfect reason to contact them directly. But just look at, on the right-hand column, this Gloria C. Larson. She's toward the bottom. She doesn't work there. She's a member of their board of directors. Remember how I said that the insurance company's not planning to pay for it no matter what? Well, you have to have some outside eyes watching. If you just send it to people who work there, they're going to do what they always do. It's going in the shredder. So who I use as outside eyes has kind of changed over the years and been refined. Don't send it to Oprah. She doesn't care about your appeal. And what I like is to send it to a member of their board of directors. They don't work there. But if they're on the board of an insurance company, they have friends in high places. They play golf with the CEO. I'm going to see if they'll call him for me. And you can usually find them easily because they're on the insurance company's annual report. They're bragging about their fancy board of directors. So I go look them up, and then I go shopping. Who's most likely to lift a finger and help us? So shorthand, I'm looking for, I like university presidents of universities. They seem to like my documents, and they'll actually pick up the phone and help. I like public interest attorneys. I'm not fond of, like, the president of Goldman Sachs. I'm probably not going for bank presidents. Democrats or Republicans, if they're up for election, I'll try them. But member of their board of directors. And then when we call them, they always say, well, I don't have anything to do with that. And then I have my person say, well, you know, I would really appreciate anything that you could do. A phone call could make all the difference. I actually give them a script to say when we get to our phones. So who are these 4 people at the bottom? Hologic Inc.? That's a private company. They don't work for the insurance company. Who are they, and why did I send it to them? Herein lies an issue which is such a scandal to me. It's probably the biggest scandal in United States insurance. How many of you have insurance through your employer? I'd say most of you. 85% of the employees who are covered by insurance in this country have self-funded plans. Let me get some water here. They're insured under self-funded plans. Oh, don't do that. And how many people know what a self-funded plan is or what it means? It just bears out what I say. 85% of the employees in this country have it, and 0% know they have one or what it means. That tells me that it's being kept from you. And your only homework today is to go home and find out if you have a self-funded plan or a traditional insurance plan. It's okay. With a traditional insurance plan, the insurance company pays for your medical treatments. Therefore, they're the final decision makers about what treatments you get. In a self-funded plan, it's your employer who pays for your medical treatments. If you work at a hospital, it's probably a self-funded plan. And if your employer is paying for your medical treatments out of their checking account, they're also the final decision maker about what medical treatments you will get. You'll never know it. All the letters come from the insurance company. The insurance company is kind of protecting the employer, so they don't have to really deal with it. But if you're going to get to the bottom of this, you have a self-funded plan. Copy the 4 highest executives at your employer. Just send them a copy. I don't overplay my hand. I just want these people at the employer to know that I know that they're involved. They'll be approving it before you know it. So let's go to the other page, second page. This is page 2. It's got to be almost as good as the first page, you know. So what's so exciting about a table of contents? Isn't it just a list of what pages things are on? No, this is strategic. These are like the scandalous titles from the National Enquirer. These titles are meant to make whoever these people reading it go, oh my God, and to be drawn in and to read more. These aren't just titles. Look at this. Local doctors offer palliative care only. A story of mistakes, misadventures, and missed opportunities. Ouch. That's embarrassing. Or Blue Cross Blue Shield of Massachusetts, rationale for decision not supported by facts. Ow. So this is the whole case in a nutshell right here. I throw in a little law, but I think the most powerful part of any of my documents is the bad medical story. It's where I say a story of mistakes, etc. We all have them. You know, when they told you you had, well, you're probably just perimenopausal. It's probably just acid reflux. Why don't you take some Prilosec? Well, you must be stressed out. It's just ovarian cysts, fibroids, endometriosis. There's nothing wrong with you. You don't have cancer. The wrong surgeries for the wrong things, the bad advice, it didn't turn out well for us, the misread scans. Uh-oh, something's ringing. I think that's mine. Oh, it's mine? Oh, no. Sorry. I guess this proves I'm not perfect, right? He knows I'm here. Turn this off here. Sorry about that. Yeah, they heard I was here. I'm going to turn it off completely there. Sorry. Yeah, that's mine back there. So where were we? The bad medical story. So all those things that we feel so upset about, it's going right into your appeal. It's the very first part. Because I think for insurance companies, they feel like in-network doctors are not really doctors to them so much. They're not really there to diagnose and treat diseases. To the insurance company, you always have to think about your audience. They're more like agents of the insurance company, there to control access to treatments. So when they make mistakes, it's kind of embarrassing. They kind of don't like it. They really would not want anyone else to see all this story. And you know what the fastest way to get rid of it is? To pay for it. So be sure to include that. Now, I'll let you study the rest of this. I come right at their medical policy statements. I address every reason they put in that denial letter. And the very last section is where I prove medical necessity. Now, what does medical necessity mean? People think they know what it means. Does it mean you need it? Does it mean clinically appropriate? Does medical necessity mean you need it to treat your disease? Insurance companies deny things as not medically necessary all the time. In order to combat it, we need to know what that means. It doesn't mean any of those things. Because in this context, medical necessity is not a medical word. It's a legal phrase. It means whatever the insurance company says it means. It's not medically necessary because we say so. I love that. Very easy to win, because you just take their definition, look it up. Look up your own insurance company's definition of medical necessity. It's there on the internet. And then you quote the entire definition in your appeal, and you prove that your treatment is medically necessary, point by point, by their own definition. That's all you have to do. And then the title is, this treatment is medically necessary, per Blue Cross Blue Shield of Massachusetts' own definition. Slam dunk. Easy peasy. So, have we made progress in the past 8 years with insurance companies paying for cytoreductive surgery in HIPEC? We have made great strides. 8 years ago, all the major insurance companies routinely denied this treatment as experimental for appendix cancer. And 8 years later, they don't anymore. As a matter of fact, most of the large insurance companies routinely approve this for both appendix cancer and peritoneal mesothelioma. Now, I attribute this, I don't work at the insurance company, so I don't know how this works. I just know that they don't care too much about science, and they only start approving things when it becomes so ridiculously, absurdly out of sync that they sort of have to. But in the state of Washington, my Blue Cross Blue Shield is Regents Blue Cross Blue Shield. And in 2008, 2009, I fought 7 appeals against them, one after the other, for appendix cancer. Patient gets diagnosed, Regents denies it as experimental, I write a 40-page appeal, I win it. 3 months later, here comes another one. They get diagnosed, they deny it as experimental, I did this 7 times. And then when the 8th one came up, I went to their website to look for their medical policy statement for HIPEC, and it was gone. So when I contacted them, I said, "Where'd it go?" She said, "Well, it's been archived." Archived, I said, "What does that mean?" She says, "We're no longer going to deny this as experimental." Kind of warmed my heart, you know? Yeah. So we've made a lot of progress. And where I see things going is that I've seen lots of cases this year for people with colon cancer. I believe that colon cancer is the new frontier for insurance progress, shall we say. And why do insurance companies willing to pay for this for those of us with appendix cancer, but not colon cancer? Because there are relatively few of us and a gazillion people with colon cancer. They just don't want to open those floodgates and give people the one treatment that is effective for their disease and which would save them a ton of dough. So I'll just keep writing those appeals. Maybe after another 3 years, we'll see a few mysterious shifts in their policy. And also, the physician scientists who are out here publishing all this data, all these massive long-term good outcomes, I believe all of that factors into it as well. So now you know that no appeal was ever meant to lead to an approval. You should know it. And that you have to not comply with their process, but you have to overcome it. You also know that when an insurance company denies something or says it's not a covered benefit, gives you a time limit, it's not the law. It's just what they say. If this were about insurance, I wouldn't spend 1 minute of my precious time on it. I did an appeal for a nice, very wonderful lady in Colorado, and back in 2009. Her name was Amy. She had ovarian cancer. She had Kaiser. I wrote an appeal to get her to Dr. Sugarbaker for this treatment. A month later, here came another gal in Colorado with the same insurance company. So I said, "Amy, would you tell her what it's like to work with me?" I did the second appeal. I won it. And at the end, I said, "So what did Amy tell you about me?" And she said, Amy said, "This is not about insurance. This is about life." The best way to win these appeals is to embrace them. These cases are very winnable. And by winning one, you will be transformed. Thank you.
Thanks, Laurie. And thank you for all your efforts on the behalf of all the patients and that you've helped and over the years and everything. If we could have Laurie and Dr. Greiner and Dr. Misdraji come up, Dr. Sullivan, you could all come up to the front. And we have some time for questions if people can stay for a little bit. And also, but I have one question actually to start off for Laurie. I hear through the grapevine that in addition to being calling the insurance warrior, you have some other nicknames.
I do.
Can you think of one of them in particular?
Oh, yes. They call me Toddzilla.
And on that note, there's a special gift for you.
I'll wear it with pride when I win my next appeal.
Great.
Thank you.
Does anybody have any questions for any of the presenters? Unfortunately, Dr. Sardi had to leave early, but if there's any surgical oncology questions, I can try to answer them for him. Yes.
I have something for Mary. So many people that I've talked to that have had MyPac and the Mohs operation, we all seem to have back problems. And nowhere in any of your stuff mentioned how to heal your back. All of us seem to be hunched over and have, it's hard, it's even now hard for me to sit up 2 years later. And pretty much everyone I know has got some kind of back issues, and you didn't mention anything about back therapy.
Is this on? Yes. Well, the talk that I was doing was more directed towards exercise and cancer, period. That I have to say that personally in the practice with Dr. Lambert, that's something I'm just starting to notice. And I think some of it is the extent of the, remember, I'm not a physical therapist, I'm a nurse who sort of has become a jack of all trades because I never had places to send people for this stuff. That, but all of the muscle disruption, what we have started doing, or I don't know that it would help you, although you could certainly go for a physical therapy referral at this point. There are two things that happen. When the scar ridge gets really tight, people compensate by bending forward, and at 12 weeks, then I can start myofascial release techniques that I start by teaching our patients how to do it. And people that can't be that aggressive with their own muscles, I started out in rehab, so I know in our own area loads of physical therapists that I can send people to that do that manually or by hand. The other key is to get people standing straight as soon as possible. And Laura does it as well now. That I often just bring people to the wall in the clinic, and it is amazing that they cannot get their shoulders back. And so it's something that to start slowly. It's like everything else, though. Because it hurts, it's hard to do it in the beginning, and it's one of the things that I find that people tend to abandon. That and that isn't in our exercise book, nor is it in the trial. But that's something we can't start those exercises till we're beyond. I think one of the things that I didn't mention in the talk about the exercise trial and the problems that we have, most patients don't go back to any type of exercise till those 12-week abdominal cut restrictions are lifted, and we lose a lot in that period of time. And for each day that you spend in bed, it takes 2 days to get the stamina back. So if we're 12 weeks into it, now we're 24 more weeks before you get there. It's part of the reason that we worked with Joe in trying to come up with things we could do to get started. But that would be something that I would consider a physical therapy referral. They have the most impact on back problems, and interestingly, except for people that have true spine problems, the majority of back problems are related to weak abs.
speech. It's a question for Laurie.
Yes.
Have you experienced any issues with Medicare?
I have given a lot of free advice to Medicare people. Medicare is very appealable. It's just that it takes too long for me to be able to do it. So, yeah, Medicare is very appealable. Has Medicare denied this for you?
No, I'm just curious.
Medicare doesn't usually deny this. They just hardly pay anything. I think it was Dr. Sardi that said he fought a fierce battle to get, because apparently they denied it for some reason. And when he finally got all done fighting for the HIPEC codes, they paid $20. So the problem with Medicare is they don't pay very well for this surgery or for the HIPEC. But they don't usually deny it. But I would say for people with Medicare, they're very appealable.
Dr. Greiner, I think that's right. I'm fascinated with your mouse research, and I'm just wondering, a lot of the reading that I've done brings up the question mark, and Dr. Sardi mentioned it too, about the antibiotic therapy, and then international treatment that my brother and I have researched has been putting baking soda directly on this stuff. Is that something you might throw at these mice? Either one of them, in addition to chemotherapy?
I wish it would work. I would give it a try if it did. But no, that's stuff like that you could never go try in people. You can line up a couple mice and give it a shot. I mean, nothing is out of the question in my mind in terms of giving it a try, because it can be so simple to try it. Why not? I'm not one of the scientists that sits back and theorizes and hypothesizes all the reasons something will or won't work. I'm one of those people that just says, just do the damn experiment and see what happens. And so, yeah, if it's a good idea and it's something that there's a reason to give it a shot, there's no reason not to.
Hi. Just going into the H. pylori, if the H. pylori in the lab work was negative, do we ask for the tumor itself to be tested for H. pylori, or is it, if it's negative in the blood, it's going to be negative in the tumor?
I think I could probably answer that one. So it would definitely be in the tumor. That's where they want to look for the H. pylori, is in the tumor. Yeah. Yes, you still need to check, because the H. pylori lives in the intestine, so we don't want it in the blood. So if it's in the intestine, in the appendix, and then it gets in, it can be in the tumor, and that's where you are going to look for it. Any other questions? Well, thank you all for coming and for staying, and we'll hope to see you next year.
I do, over here in the corner, I have my material. Oh, no, it's wonderful. Thank you.